Yes, ma'am, we are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with AMPOGS. It's my privilege to introduce the coordinator of today's webinar, Dr. Monica Umbadan, ma'am. Ma'am is the consultant obstetrician and gynecologist at Mangalya Nursing Home and Atava Fertility Center.
Saiti, it's okay, Saiti. It's
Yes, ma'am.
okay.
I welcome you and I hand over the session to you, ma'am.
A very warm welcome to all the esteemed faculty members and the delegates who have joined online today for the 40th episode of the Emergency Obstetric Committee of AMOGS in association with AMPOGS with our four societies, that is Ratlam, Rewa, Sagar and Katni. We thank Kavita Madam, Dr. Deepti, and all the presidents of the four societies, that is Dr. Jyoti Madam, Dr. Vandana Madam, who have given the permission and have been able to participate in this esteemed program. This is the 40th episode, and the brainchild is none other than Dr. Sneha Bhuiar Madam. She is the chairperson of the Emergency Obstetric Committee. She has been the past chairperson of the Foxy Breast Committee. We welcome you, ma'am, and we invite you to address our gathering. Saiti, can we have the lamp lightning before Madam addresses? Yeah.
Yes, ma'am.
I think Saiti can stop sharing. A very good evening to one and all. My respect and regards to all the seniors here, especially our AMOGS President, Dr. Kiran Kurtakoti, and AMPOGS President, Madam Dr. Kavita Singh, as a chief guest, and also the guest of honor, Dr. Leela Joshi, Madam, and of course, Dr. Neena Gideon. I thank AMPOGS as well as all the societies of AMPOGS, for having this collaboration. I thank all the president, secretaries. I welcome all of you rather for this program. This is the academic session, as you heard, it's right. It is 40th session for AMOGS Emergency Obstetrics Committee, and we are happy to have various sessions with various states. I welcome all the faculties, the speakers, Dr. Binu Kushwa, our dear friend, will be speaking on the screening, prediction and prevention of HTP. And of course, Dr. Anupama Dave, who will be speaking about the management of hypertensive disorders of pregnancy. And I will be moderating the panel discussion on hyperglycemia in pregnancy. So, friends, amongst Emergency Obstetrics Committee, the aim is to, reduce the maternal and perinatal, not only the mortality, but the morbidity also. And that is why we have been selecting various topics which are, you have to face in day-to-day practice. So, friends, once again, I welcome all of you and I thank all of you for this collaboration. And with this brief preamble, I just thank my convener, Dr. Dipti Gupta, and of course, the coordinator, Dr. Monica Umbardand also. And friends, as all of you know, don't go on my looks. I am Dr. Sneha Bhuiar with 35 years of experience in my obstetric practice. I stand before you humbly and request all of you to nominate me from your society. And please, please do share my vote appeal to your members also. And please see to it that all of you vote for me so that I win. Last time, it was only 40 votes that has made the difference. So I request all of you. And of course, the academics will continue. So with this, I would like to invite Madam Kavita Singh for her, precious words of guidance. Can we have Madam CV, please? Thank you. So, Professor Dr. Kavita Singh, who is the president of AMPOGS for 2024 to 26, and she's a professor and dean, GMC Bhopal. She is the ex-professor, Department of Obs Gynae, Jabalpur, and Madam has got lots of awards and accolades. I would say Foxy Durusha Community Service Award in
चलेगा चलेगा
2020. Madam,
बस
yes,
मैडम हाँ
thank you
आप
so much, madam.
हाँ
I'm very happy that I have received the same award in 2022 and you have received in 23. We are very happy and fortunate to have you, madam. Over to you for your precious words.
yeah. So at the outset, I would like to congratulate you and thank you for this kind invitation on academic platform and collaborating with MPOX. And I am very happy to see uh, Dr. Kiran and Dr. Rajendra ji on the platform, Dr. Vipin, and our very respected Dr. Leela Joshi madam and dear Dr. Neena, Dr. Jyoti, and all my friends from MPOX. They are, so the webinar is all the MPOX star-studded looks on the screen right now. And I'm so sure that Binu, Anupama, Padma, Sunita, all the chairpersons, panelists are going to make this exercise absolutely needed and useful for serving the women of central India, whether it is Maharashtra or Madhya Pradesh. And as far as the maternal morbidity and mortality is concerned, we are struggling with the HDPs as a leading cause for increase in morbidity and mortality. So this is a topic which needs to be discussed, discussed and to be actually implemented at the grassroots level so that we pick up high risk pregnancy cases. Just last month we had our state conference at Riva, and our Minister of Public Health and Medical Education and our Deputy CM, Shri Rajendra Shukla ji, was our chief guest, and there was a lot of concern he has raised as far as the maternal morbidity and mortality is concerned. And from platform, though I am working here in capital as Dean of Gandhi Medical College, but as MPOX presidents on behalf of all the presidents and secretaries of MP, I requested, sir, and we have given a letter also to the government that we believe that there is a need to strengthen and work hard on antenatal care. And in a WHO model of 2016, we have 8 contacts, and 1 in first trimester, 2 in second trimester, and 5 in last trimester. So we are emphasizing on behalf of MPOX. I have written this letter to the ministry, and all my friends believe with me and they stand with me that there should be maximum emphasis on not only in the first and the second trimester, but the final trimester, that is third trimester. So all the sugar, blood pressure, anemia, thyroid, all the IUGR, all such problems are picked up. So they will reflect in decrease in maternal morbidity and mortality. You started with the prayer Astoma Sadagamaya, which is written, if you can read, it is written on my back. It is in our logo of Gandhi Medical College, which is there written that Astoma Sadagamaya. तो उन्हीं शब्दों के साथ में आपको बहुत सारी शुभकामनाएं मध्य प्रदेश से प्रेषित करती हूँ और उम्मीद करती हूँ कि हम सब मिलकर हमारे देश की ये जो मातृशक्ति है उसको हाइपरटेंसिव डिजीजेस के जो जानलेवा कारण है उससे कैसे बचा सकते हैं, इस पर विचार मंथन होगा। मेरी आप सभी को बहुत सारी शुभकामनाएं। मैं थोड़ी देर में अपना वीडियो ऑफ करूंगी, कुछ और काम है, मैं काम भी करते रहूंगी और इन बिटवीन आपको सुनती भी रहूंगी। सो वंस अगेन कॉन्ग्रेचुलेशन डॉक्टर स्नेहा एंड बेस्ट विशेस। अभी आप 40 से बोल रहे हैं मुझे कि 40 वोट से ऐसे हुआ, हम MP आपको दुआ करते हैं कि आप 400 और 4000 वोट से और आगे जीते, ऐसे हमारी शुभकामनाएं। एंड बेस्ट विशेस टू मोनिका एंड लव टू दीप्ति and for coordinating this session. Thank you so much. Namaskar.
Thank you, madam. Thank you for that, very precious words of guidance. We really need to implement as what you have, said, and everybody has to start practicing what actually we are learning. So thank you so much, madam. And over to you, Monica, for the proceeding.
I take privilege in introducing our AMOGS President, Dr. Kiran Kurti, sir. Sir, thank you for being the guiding force behind these webinars. And I know you don't like so much of introduction, so I welcome you for your presidential address, sir.
Thank you. Thank you so much. At the outset, warm wishes from AMOGS family to all of you. Regards to Dr. Kavita Singh. Dr. Kavita Singh, namaskar. Always AMOGS and AMPOGS always are together. Dipti ji, nice to have you in Pune. Hope to have you back in Pune sometimes or the other. Today's guests of our honors, Padma Shri Dr. Leela Joshi Madam, Dr. Neena Gidon Madam. Namaskar on behalf of AMOGS to all of you, and of course Monica, Dipti, and of course who we can forget, Sneha. Sneha, I know that the figure 40 haunts you, but I think अब की बार 400 पार होगा तो अब की बार 4000 पार मैडम ने बोला है तो हो जाना चाहिए. So let us see, hope we should pray that it is successful. Now coming to the topic, that is HDP. Two things that we have done or are planning to do in AMOGS. One is implementation of the Gestosis score. So Gestosis score, all the World Gestosis Organization, and Dr. Alpesh and Dr. Sanjay Gupte and Dr. Gorakh have been working tirelessly for this implementation of Gestosis score. So what we have done as far as AMOGS is concerned, that we have shared the Gestosis scores to everyone, and we would request everyone to implement the Gestosis score or see all the patients, screen all the patients as per the Gestosis score. So this is number one. Number two, what we have requested our ministers is that during the entire pregnancy, wherever a gynecologist is available, the antenatal patient at least should be screened for 5 times by a gynecologist. So for which our gynecologists are ready to offer their services free of charge on any particular day. This could probably bring down the maternal morbidity or mortality. So this we need to implement, because what happens is in the state of Maharashtra, there are many non-gynecologists who are practicing. Nothing against non-gynecologists practicing or doing antenatal care. They are giving out service. However, if a gynecologist who is actually trained in that, he or she examines such patients at least for 5 times during the antenatal care, then probably the incidence of hypertensive disorders in pregnancy and the morbidity and mortality associated with that can go down. So these are the two things that we are going to implement in AMOGS, and if at all it is feasible, you can do that in MP also. So with that, I think my best wishes, Dr. Sneha, Dr. Dipti, Dr. Monica Umberdan also is there. So Monica is also there in some fray or the other. So best wishes to all of you, and hope a lot of collaboration with AMOGS, all the AMPOGS committees also in the future. Thank you.
Thank you so much. Thank you, Dr. Kiran, for, always your support and best wishes, not only for the programs too, but to all of us, and looking forward to your support, of course. So thank you so much once again. And may I now invite our guest of honor, Padma Shri Madam Leela Joshi ji. Madam Leela Joshi, Madam Leela Joshi is retired as the Chief Medical Director, Indian Railways, Assam, and settled in Ratlam with a mission to reduce maternal mortality by eradicating anemia in tribal, rural, and underprivileged section of the society. Ratlam is a tribal majority district of MP. She is continuing it for last 24 to 25 years and still continuing the same at the age of 85 years. So taking advantage of her, transferable job all over India, she started 3 Foxy branches at different places. They are Kota, Dehradun, and Ratlam, and she has innumerable honors and awards to her credit. Few of them are 100 Women Achiever, Women Pride Award, Pride of Foxy, Devi Award, and of course Vishwa Seva Ratna Award. So one of the highest honor, that is Padma Shri, as you can see. So with this brief introduction, may I invite Madam Padma Shri Leela Joshi for her precious words. I think Madam was here just now. Can we see her? Okay. So I think by the time we can have Madam Nina Gideon's words. So Monica, if you can introduce Madam by the time
Yes, ma'am.
call Leela Joshi Madam. Yeah.
Respected Dr. Nina Gideon, Madam, has been the Vice President of AMPOGS in the year 24-26, the President of IMA Sagar 2019, President of the Sagar OBGYN Society in 2010 and 18. He has been also the Organizing Secretary of AMPOGS 2016. She has been the faculty for the CPS course for DGO since 2019 and a master training for GDM and screening of cervical cancer. She has received the Women Empowerment Award by IMA, the National EFCON Goa 2019, the Wonder Foxian Award, and the Nari Swastha Pahel Award. She has also received 11 national awards of Foxy during her tenure. We welcome you, ma'am, and we request you to please address the gathering.
Okay. Thank you. Thank you for kind words. And thank you very much for making me a part of this webinar. Really pleasure to be here. At the outset, let me congratulate Dr. Sneha Bihar ma'am she is a gifted teacher who has mentored numerous students and conducted many webinars, seminars, workshops, conferences, physically as well as online, and sharing her knowledge and expertise with passion and enthusiasm. She is an accomplished gynecologist known for her exceptional clinical skills, inspiring future generations. My best wishes for your future tenure, venture, and success in Vice President election, madam. This year, definitely you will be on the top.
Thank you, madam.
I'm deeply honored to share this platform with the esteemed Padma Shri awardee, respected Leela Joshi, madam. Her remarkable contribution to the field of medicine, particularly in the area of women health, especially anemia, have been truly inspiring. As we know, MMR of MP is very high. Government has implemented several initiatives to tackle high-risk pregnancies. Many conferences and workshops are being conducted on it. Recently, Dr. Binu Kushwaha organized a successful workshop on critical care in Riva. What I mean to say that as we know, obstetrics is unpredictable. So we have to keep our index of suspicion very high. And with devotion and dedication, we have to work for early detection, proper management of high-risk pregnancies. And one more thing I want to say, that most of the high-risk pregnancies, they turn into cesarean section. And that leads to PPH. There are chances of PPH. So I will request all of you to please apply Gideon suture prophylactically to prevent PPH and to reduce maternal mortality and morbidity. And my best wishes to all chairpersons and experts, Dr. Padma, Dr. Sunita Vadhwani, and to all academically sound panelists, and of course, and learned speakers, Dr. Anupama Dave and Dr. Binu Kushwaha. Now, waiting to hear from all of you and wish you a success for this webinar. Thank you very much.
Thank you. Thank you, madam.
Sneha ma'am, Leela ma'am is coming back because I cannot see her online.
Dr. Dipti is calling her, but maybe I think
Yes.
we will have her words once she joins. So
Sure,
I
ma'am.
just say,
But I couldn't connect.
okay, no worries. So I just thank, with the blessings of God Almighty and our respected seniors, Dr. Kavita Singh and Dr. Kiran Kurtakoti, the AMPOGS and AMOGS president respectively, and of course the guest of honor, Padma Shri Madam Leela Joshi and Madam Nina Gideon. All the faculty.
Madam, excuse me. It is pronounced as Gideon. Dr. Nina Gideon.
Gideon. Yeah, thank you.
Gideon.
So, with this, ma'am, we declare that the inauguration has been completed and we move forward to the academic session. Chairpersons for the first session are Dr. Vandana Gupta, madam, and Dr. Jyoti Chauhan, madam. And our speaker esteemed for today, Dr. Beenu Kushwaha, ma'am. Dr. Vandana Gupta, madam, has been the president of the Katni OBGYN Society, the director of the Om Shanti Maternity Hospital, the founder vice president of Katni Society, the vice president of IMA Katni, member of the AGOI, and she has been working since last 22 years in Katni as a parent consultant. Her areas of interest include HPV vaccination and cervical cancer prevention. Our next chairperson, Dr. Jyoti Chauhan, madam, is the president of the Sagar OBGYN Society. She is the ex-regional director of the Sagar division. She has been the gold medalist and the first position in the Rajasthan board. And she is the president of the Union of JN Medical College, Ajmer. She has presented various papers in national and international conferences, and she's a fellow of the International College of Maternal and Child Health. She has been serving as the secretary of Sagar branch, and she's received the National Award, the Nadkarni Trophy, for the activities during her secretaryship. We welcome both of you, ma'am, to chair this session and introduce Dr. Beenu Kushwaha, ma'am, for her talk.
Good evening, all. Thank you, Sneha ma'am, for involving Katni OBGYN Society in this prestigious webinar. And I am happy to introduce Pyari C. Mardu Bhashini Beenu Kushwaha, madam. And she is She is professor in Central Head Virsa Mudda Center of Excellence, Department of OBGYN, Riva, MP, and she is vice president and she is chief editor AMPOGS newsletter and president ISO Parv Vindhya chapter. And she got many awards like Best Girl Student Award MBBS 1996 batch, and she awarded by International Journal of Obstetrics and Gynecology research article for year 2009 on medical abortion, and uh, and she got AOGD silver medal for paper presentation 2008, and she Foxy West Zone Kamini Rao oration of year 2015. And
Madam,
she got
thank you for introducing. You are introducing me. That is good enough for me. Thank you so much. Good evening, ma'am.
good evening,
Yeah.
Binu. So you are amazing as a speaker. So
Thank
good
you so
evening.
much, ma'am. Thank you. Thank you. So should I share my screen, ma'am, now?
Yes, yes, my dear. Go ahead.
Is it visible, ma'am?
No. Binu, I think it hasn't started. Have you clicked on the share screen icon?
Yes, yes.
No, we
Is
can't.
it showing now?
No.
Oh, because on my screen it is showing.
Saiti,
No.
can you please help?
Please click on the share icon.
I
Then
did that.
please click on the screen and then blue color share.
Just a second.
2 times share, ma'am.
Share screen first, then share.
No.
Yes, ma'am. Yes, ma'am. Now your
Yeah.
screen is seen. You can open
Just-
your PowerPoint. Yes, ma'am.
Yeah.
Perfect, ma'am. Please
There?
go to the
Yeah.
slideshow mode.
Yeah.
Perfect, ma'am.
Thank you. Thank you. So, good evening, everyone. It's my proud privilege to be speaking on this platform. And at the outset, I'm really very thankful to Sneha ma'am for giving me this opportunity. My topic for today's webinar is prediction and prevention of hypertensive disorders in pregnancy. So it is a vast topic. For at least a half-day webinar can happen on this topic itself, but I would only like to touch upon the points which are really going to help in clinical practice. So I would start with the background that traditionally pregnancy management involves handling with problems as they appear. As most of the maternal and fetal complications emerge late in pregnancy, most of the focus so far has been put on third trimester. But in recent times, role of prediction and prevention in the field of obstetrics has evolved in a big way, as we all talk about the inverted pyramid of antenatal care. So prediction is basically done for the problems which have major impact on maternal and neonatal morbidity and mortality. So what is the burden of problem that we are talking about? So if we talk about the global incidence, it is somewhere around 2 to 8%. But Indian literature states its incidence ranging from 10% to 15%. And it is actually the second most common cause for maternal deaths after hemorrhage. And at many places, it tops the cause among maternal deaths like ours. Even at our hospital, it is the most common cause for maternal deaths. As per some data, it is responsible for up to 20 to 25% of maternal deaths, and it is an important cause for iatrogenic preterm births and stillbirths directly or indirectly. Also, if it causes IUGR or other fetal problems, then it may cause a fetal origin of adult diseases through Backer's hypothesis. So it is a big burden on us as obstetricians. So is it okay to predict HDP or screen it in pregnancy? Why do we really need to predict it? So if we want to predict any disease, it should fulfill certain criteria. First of all, it should be an important public health problem. We should know about the etiopathogenesis of the problem, and it can be prevented by one or the other intervention, and the prediction or screening tests should be available which are feasible in a particular setup. So as we can see that HDP or hypertensive disorders in pregnancy fulfills all these criteria. It is a major public health problem in obstetric population. We know about its pathogenesis now. It can be prevented by administration of aspirin, and then we do have tests which can predict it quite fairly. Talk about the tools and modalities which can be used to predict hypertensive disorders in pregnancy. They can basically be classified in four categories. First is history based risk factors, then the baseline blood pressure. Here we take mean arterial pressure, then biochemical markers like PLGF and SFLT, then biophysical markers like uterine artery Doppler. So these four are the basic categories of the tools which can be utilized for predicting hypertensive disorders in pregnancy. So first of all, we gather the clinical information through a very good history. Then we take a blood pressure of the lady, and here it is mean arterial pressure. Then we take a blood sample of the lady for certain biochemical markers, do an ultrasound to look for uterine artery Doppler, and then based on the result, we divide the obstetric population in two categories, that is high risk and low risk. The low risk ladies would be followed as usual, and the high risk would be monitored more closely, and certain interventions would be done. So coming to maternal characteristics, they are basically based on the history. So a very good history taking at first visit is the foremost thing which we need to do to predict hypertensive disorders in pregnancy. And as I always say, history just cannot be bypassed. So here also in history, you need to take demographic characteristics of the lady, medical history, and the present medical status of the lady, past and present obstetrics history, and also even the family history is important to take. Then, based on these characteristics, many of the societies all over the world have come up with the risk factors, which can be divided as moderate risk factors or high risk factors, like ACOG, NICE, ISS, HP, all have same, more or less same risk factors, which have been categorized into moderate or high risk factors. Like a previous pregnancy adverse outcome or previous preeclampsia is considered to be a moderate risk factor. But if she has chronic hypertension, it is considered to be a high risk factor. So based on presence or absence of these risk factors, ladies could be categorized as high risk or moderate risk. Then, as sir also highlighted, that we have our own gestosis score that has been developed by Foxy, and it is a very easy app which can very easily be downloaded on an Android phone. And through this app, you can actually calculate the risk of the lady. It also includes mean arterial pressure in the score. So this is the score. So on the basis of risk factors, there are three categories of risk factors: mild risk factors, moderate risk factors, and severe risk factors. In mild risk factors category, each of the factor has been given a score of 1, in moderate 2, and in severe 3. And if we add all the risk factors that a lady has, if the score comes out to be 3 or more, she is considered to be at high risk of developing hypertensive disorder in pregnancy in coming days. So this should be in everyone's phone. So next comes, so these we talked about the maternal characteristics that we need to take care of, we need to know about. Next comes the next modality, that is uterine artery Doppler. So nowadays, almost in all setups, if we leave alone the very small setups or villages, we are doing the anti-scan, anti-NB scan at 11 to 13 weeks as a part of aneuploidy screening. So during that scan only, we can also perform uterine artery Doppler, and it gives us lots of information. The only thing, the timing should be correct, and also the person who is doing this ultrasound should be a experienced one. So on right side, we can see the flow that is there in a normal pregnancy and the flow in a pregnant lady who is prone to develop HDP. So the main things that are there concerning this uterine artery Doppler are, it is most beneficial if done between 11 weeks to 13 weeks. For two reasons, that the risk calculation is best if you are doing at first trimester, right? Then the detection rate is best. Second reason is that the aspirin which we give to prevent HDP gives best results if it is started early, like from 11 to 12 weeks, when this whole desitualization process of spiral arteries is going on. So before that, you are supposed to give the aspirin to gain maximum results. So it would be most beneficial if it is done between 11 weeks to 13 weeks. Now, obviously, by an experienced sonologist, as I said, then average PI of both the uterine arteries is to be calculated. Presence of notch, basically, it is the uterine artery PI which is of concern here, but presence of notch also should be seen and documented. Early diastolic notch may be a normal finding in a normal pregnancy, but it may be an abnormal finding if it persists even during the ultrasound, which we do later at 20-22 weeks as target scan. So it would be really nice that we document this presence of notching at early trimester ultrasound, and then we look for it at 20 weeks scan also, whether it is persisting or not. So if it persists, then only it is abnormal. It can also be done at 24 to 28 weeks, this uterine artery Doppler, because as we see that many of the patients come to us for USG later, like after 20 weeks. So it can be used till 28 weeks to predict the possibility of HDP. So it is an important tool at resource poor setting. Resource poor setting, I mean to say that when you do not have biochemical markers available at the place. I will show it in my next slides also, that it has got a fair sensitivity and specificity and a detection rate when combined with the maternal risk factors. So just do not worry if you do not have the biochemical markers available at your place. You just go for the uterine artery Doppler along with the maternal risk factors. So next comes the biochemical markers. There are many markers which have been explored for predicting the hypertensive disorders in pregnancy. And as we know by the etiopathogenesis of hypertensive disorders in pregnancy, it is basically the imbalance of biochemical markers that makes a lady prone to develop hypertensive disorders in pregnancy. And three main markers which have been explored in this area are PLGF, PAPE, and SFLT1. Among these also, PLGF is the main marker, placental growth factor. So if it is reduced, it means there is a abnormal placentation. So it is utilized as the main marker, and it is best done in first trimester if you want a good detection rate. PEPE also we can utilize, because I have seen nowadays double marker testing is also being done very frequently. So from there we can use the values of PEPE, but this SFLT1 is mainly used in late trimester and in combination with PLGF to actually predict the adverse outcome of the pregnancy or to time the delivery. So it is nowadays mainly used for in late trimester. So what is the best way? So triple or combined test is the best way. FMF or Fetal Medicine Foundation preeclampsia triple test, as it is called. So they say that the clinical parameters with mean arterial pressure, uterine artery Doppler, and biomarkers, when they all are combined, they give us the best predictive value to predict hypertensive disorders in pregnancy. So this is these are the detection rates of different approaches for predicting developing HDP early or late. Early we call it when the HDP is developing before 30 weeks, and late when we call it when it develops after 34 weeks. Mainly, all of them are more predictive of early HDP, early preeclampsia. So if we utilize only the maternal factors, the detection rate is 53% for early preeclampsia. If we add mean arterial pressure to that, it increases to 61%. Then if we add uterine artery Doppler in maternal factors, it comes to 70%. And more importantly, if we add only these three, like maternal factors, mean arterial pressure, and uterine artery Doppler, PI, then it raises to 83%. And any test which gives us a detection rate above 75% is considered to be very good. So again, I'm saying, please don't worry if you do not have biochemical markers available at your place. You at least combine these three. And even if you do not have uterine artery Doppler facility available, at least do these two, like maternal risk factors and the mean arterial pressure, that we do by our gestosis score as well. And if we combine all of them, look at the detection rate. It is like up to 90%. And many studies are coming up which are saying that detection rate is up to 99% actually, if we do them at right time, especially for early HD. So what can be the way in clinical practice? So in clinical practice, as we are doing our double marker already, we can take out value of PAPE from there. And if we are doing this anti-scan already, then we just need to add uterine artery Doppler to that. And look at this, the bottom line. It says that if we combine PLGF, PAPE, uterine artery Doppler, and maternal mean arterial pressure, along with maternal history, the detection rate for early PE is up to 100%. That's what I was telling. So this is the best thing, but it's fine if you do not have the biochemical marker. You can do with your uterine artery Doppler and maternal risk factors and mean arterial pressure also. So this is the best way forward. The best combined test is one that includes maternal risk factors, mean arterial pressure, serum placental growth factor, and uterine artery pulsatility index. And if not possible to measure PLGF and or uterine artery pulsatility index, the baseline screening test should be maternal risk factors with mean arterial pressure, and not maternal risk factors alone, because there the detection rate is lesser. If PAPE is measured for routine first trimester screening for fetal aneuploidies, the result can be included for preeclampsia risk assessment. Then we have this beautiful FMF calculator, Fetal Medicine Foundation calculator, that is available online. Most of the radiologists have it on their system. You just need to put the particulars of the patient, then the mean arterial pressure, uterine artery PI, and PLGF and PAPI, whatever is available. If you don't have PLGF or PAPI, then also it is going to give you the risk that is calculated from that much available information. So you can ask your radiologist at least that please give me a risk from this FMF calculator. Then not only the early pregnancy prediction, nowadays we have come up with so many biochemical markers which can be done throughout the pregnancy, like to predict the possibility of HDP or even to predict the adverse outcomes during pregnancy. So nowadays it is especially the this SFLT1 and PLGF ratio which can predict the adverse outcomes, and it helps us to time the delivery. So why not to utilize these markers and give best to our patients? So this is the latest thing. This was Iceland. There is a place called Parrot something Island. So wahan pe they did a study called as Parrot study, in which they actually highlighted the importance of PLGF testing to be used for triaging. Like if the value is more than 100, then it is normal. Between 12 to 100, it is low. Below 12, it is very low. So by this, they just triage the patients and they manage them, as the patient can be managed as an outpatient based patient, or it should be admitted, and also to time the delivery. So then if the lady is very sick, now, like this was like in late pregnancy, you can utilize SFLT and PLGF and the PLGF triaging thing to get them admitted or not. And then comes the, when a lady comes to you, you can directly put this information like FMF calculator or gestosis score into full Pearson and mini Pearson scoring system. Mini Pearson is used at a very low resource setting. Nowadays you have this Unmol app and so many pregnant women tracking apps which are there on the phones of ashas and ANMs, so they can utilize this mini fire system, prognosticate the patients, whom to be referred, whom to be put at their place only. So in lower and middle income countries, they have come up with mini fires where you only need to add maternal characteristics, systolic blood pressure, and the dipstick proteinuria status. Based on that, they would decide, they would triage the patient, they would refer or they would keep the patient at their place. Then we can add further platelet count and serum creatinine at mid-level places, mid-level hospitals, to further prognosticate the lady. And there is a full PIRE system which could be utilized at a tertiary care center to prognosticate a lady of or hypertensive disorders in pregnancy. So there are so many things which are available to predict the possibility of developing hypertensive disorder in pregnancy. And not only that, we also have the scores which can predict the adverse outcomes once the lady has already developed preeclampsia, and also can decide the timing of the delivery. That prediction can also be done with the utilization of these biochemical markers and scores. So after prediction, I come to the prevention of preeclampsia. So so far, it is only the aspirin. It has got a proven role to prevent preeclampsia. That too, if it started in late first trimester from 11 to 12 weeks of pregnancy. That has been proven by all the trials like aspirin, all. Calcium intake, per se, additional calcium does not prevent the development of preeclampsia, but a usual calcium intake should be maintained, that is 1000 mg per day. There is no role of nitric oxide donors, so please do not give those arginine sachets and all those things to these patients. Vitamin D supplementation may help. Actually, vitamin D has come up as like हर चीज की दवाई, तो हम शायद इसका जो usual intake है that should be maintained. But there is no role of vitamin C and E supplementation. So those Evion Fort and everything, I don't know how much role they play. Also, fish oil rich diet may help, but it has not been proven yet. And no salt restriction whatsoever. Actually, it may cause more harm. So, lady is supposed to take normal salt, right? Not excessive and no restriction. So, what about the guidelines? After discussing all these things about the prediction and prevention, what actually the guidelines say? So, FIGO guidelines are the most appropriate guidelines for us. Like ACOG and NICE are, although they are the developed countries, still they say that maternal history-based risk factors and mean arterial pressure are the best methods to predict preeclampsia, but the incidence of HDP is not that much in their setup. So I would say we should not go by their guidelines. We should go by the guidelines which should suit us the most. So FIGO is the society which takes care of low resource setup also and low and middle income countries as well. So what FIGO says? FIGO says that yes, to all the patients, universal screening for HDP should be offered between 11 to 13 plus 6 weeks of pregnancy, and it should be the combination of maternal risk factors and the biomarkers, which includes ultrasound and chemical markers both. So that would be the ideal situation. But what about the resource limited places? Routine screening for preterm preeclampsia by maternal risk factors and mean arterial pressure should be completed in all pregnancies. At least this much we should be doing in all pregnancies during early trimester, during early visit. And then if we talk about the prevention of preeclampsia or HDP, then the women identified at high risk should receive aspirin prophylaxis at 150 mg per night. Here also you need to be really aware about the dose. If a very good weight patient is being given only 75 mg of aspirin, there is no value. So you need to be mindful of that. Also, the recommendation is of 150 mg per night, unless the lady is thin-built. Commencing from 11 to 40, actually 13 plus 6 weeks of pregnancy may extend to 14 plus 6 weeks gestation and to be continued until 36 weeks. So with that, my take-home messages would be screening for HDP should be offered to all. Combined screening is the best method. In resource-limited settings, maternal risk factors combined with MAP should be the method of choice. And if possible, if we are doing anti-scans already, start combining it with uterine artery Dopplers also. And please give low-dose aspirin. And low-dose aspirin doesn't mean 75 mg. It is 100 to 150 mg that has been tried in all the trials. So low-dose aspirin should be given to all who are at risk of developing HDP. So with that, thank you so much for the opportunity once again. Thank you.
Thank you, Dr. Binu. You really gave a very good presentation. Yours was like a presentation that should have been given at the national level. And there were so many recent factors that were included. But I wish to add from my last 40 years of experience as a regional director, I've had the opportunity of visiting even the remotest areas of the 6 worst districts of my division. So I can tell you there are factors other than these that are actually responsible for our maternal and neonatal bad status of mortality and morbidity. So kept aside.
Very true, ma'am. Very true, ma'am. And we should actually share those factors to really, yes, gain the results.
Platform? See, you spoke about such nice things, and now when I come to the ground reality, it would sound very bad, but the foremost factor is the lack of human resources. If you do not have the person to work there, how can you get the work done? That is the basic problem that I have observed practically. Sometimes the working conditions are not good. Sometimes the logistics are not provided timely. Sometimes the situation there of the political scenario and so many other factors, which I would not like to share on the stage, are so different in Madhya Pradesh. I've had an experience of 3 states. I hail from Rajasthan. I worked for nearly 38 years in Madhya Pradesh, and my daughter is serving in Mumbai in Reliance Hospital as a gynecologist. So I have an experience about Maharashtra as well. I get to know from her. So all the three states are so different. Our problems are much different from those of Maharashtra. So we should actually concentrate more on our factors, and for that, what I feel the best would be the gestosis score that actually attacks the clinical scenario. So what can be picked up from the clinical setting, I think would actually benefit us better. As for the radiologist, you said the Dopplers you were talking about, the simple radiology, out of 52 districts, only 17 are having radiologists. So we are like, what to say, we are actually fighting at all fronts. So things are so different from other states. We are really actually struggling would be the right word for us, but still we are determined to handle the situation, and we will handle the situation. What we can best do is the clinical scenario, as we can handle best would be the history taking, as you mentioned, the basic test that you mentioned, and the basic Madam Kavita was talking about the 8 tests that the Foxy recommends, but Government of Madhya Pradesh so far has recommended only 4. If those 4 are actually carried out in the manner actually stated by the government, that is, the first 2 can be done by the ANMs or the CHOs, and the third and fourth should be done by a medical officer or a specialist. If that is followed, if that is the basic thing that can be done, still we can catch hold of nearly 50% of them. Another big problem is that we need to collaborate with our politicians and the social workers and the NGOs so as to bring the patients on time. They do not report on time. Most of the time, in my districts, people working in Damo and Panna are working actually in Delhi and Rajasthan, and they come in the last trimester when they are about to deliver. Almost in the last month or in the last 7 to 10 days, they land up there. When the labor pain starts, some of them land up there. Then there is a big problem because they have not attended ANC at all. So the high risk factors have not been identified. And then to treat them, it becomes a nightmare even for the tertiary settings. So our problems are maybe different from those of Maharashtra and those of other states. So let's since it's AMPOGS, I wanted to share my inputs here. And with the data that you have provided, with the presentations that you have made, especially about the tyrosine and that placental growth factor ratio that you were talking about, that is the best. Mean arterial pressure, of course, is the golden standard. So all those factors you touched, they are really very good, and they would really benefit our PG students who are attending this conference right now. So that will not go a waste. That will teach our upcoming generations, and we will fight our problem the way we can the best. Thank you so much, Dr. Binu.
Dr. Vandana, ma'am?
Madam, yes, Dr. Vandana.
Thank you, Dr. Deep. Thank you, Dr. Binu, for a wonderful presentation. And thank you, Sneha ma'am, for your post. All the best, madam. MP says bar 400 ke par. Thank you, ma'am.
Yeah.
Oh, I need to add that, ma'am. Ma'am Sneha Buhar,
Yes,
I need to add that our society is absolutely with you. So this time, all the best from our
Yes,
side.
ma'am. Thank you.
Thank you so much. Madam, I am a common man's representative. Absolutely no nepotism. The first doctor of the family. And I'm like one of you, practicing obstetrician gynecology since last 32 years, coming up with own, and own ability and your blessings to this two national posts. Okay. So thank you so much, madam. And definitely, as you said, I would say, wonderful. Your talk is, up to the mark. Definitely, you have done justice. What message I would like to give from my side is SDP justice score. Though you may not call it as a score, but maternal characteristics, as we used to call it previously, that is the best. If all of us follow in our OPD, right from our sister who takes the initial, history, and our assistant doctor taking the patient's blood pressure on your own personally, because don't rely on the sister or the assistant doctors, because having the blood pressure with appropriate situations, conditions, or prerequisites, I think that is the hallmark that you can catch the HDP at the earliest. And of course, then you have said so many predictive tests, biophysical and biochemical. So wonderful. I'm sure at least one message: prediction is in our hand, definitely. And of course, if you can predict, you can definitely prevent at least the severity with low dose aspirin and high dose calcium. So thank you so much. Let us go.
Thank you, ma'am. Thank you.
Thank you.
Thank you, ma'am, for a wonderful presentation and an elaborate talk. And thank you, Jyoti ma'am and Vandana ma'am, for chairing the session. We next move on to the second session for today, which will be presented by Dr. Anupama Dave madam. Our chairpersons for the session are Dr. Aditi Rathod and Dr. Ruby Reja. Can we have the CV Society? Dr. Aditi Rathod is a consultant at Rathod Nursing Home, and she's an executive postgraduate program in healthcare management. She is the secretary of the Ratlam OBGYN Society, and she has been a faculty at various conferences. She has been a part of the organizing team of AMPOGS 2018 and received the PM SMA award. We welcome you, ma'am. Our next chairperson, Dr. Ruby Reja madam, is a consultant at Kemchand Jain Charitable Trust Hospital since 2004. She is been the secretary of the Sagar OBGYN Society in 2009, and she's won 3 national awards for the same. She has been the president of the same society in 2014 and 15. She has been the part of Respective Abortion in 2022 and a master trainer of the DIRA program, the Foxy Champion Award, and the Foxy Champion for DIRA. We welcome you, ma'am, and we request you to please introduce speaker, Dr. Anupama.
Good evening, everyone. It's my privilege to introduce Anupama Madam. She is organizing scientific committee chairperson AICOG 2022.
Ma'am, please unmute yourself. Yes, ma'am.
Yes. Good evening, everyone. It's my privilege to introduce Anupama Madam. She is organizing scientific committee chairperson AICOG 2022 Indore. Presently President ISOPARV Indore chapter 2022. Past Secretary ISOPARV Indore chapter 2017 to 22. Past Secretary AMPOGS 2017 to 20. Past Secretary IMS Indore 2015 to 19.
Thank you,
Organizing
Dr.
Secretary
Thank
National
you.
Conference.
It's quite elaborate. It's okay. Thank you for the kind introduction.
Thank you.
Can I start now?
Welcome, Dr. Anupam.
A very good evening to all of you. At the outset, I'd like to thank Dr. Kiran and Dr. Kavita, presidents of AMOGS and AMPOGS respectively, and my very special thanks to Dr. Sneha for inviting me to this wonderful CME. And I take this opportunity at the outset to tell Dr. Sneha that tell her about her that she's a wonderful person, an excellent academician, and I wish her all the best. Ab ki baar 4,000 par should be the slogan now.
Thank you. Thank you, madam. Thank you, sir.
Well, the topic which has been allotted to me is management of hypertensive disorders in pregnancy. Dr. Binu has told us about prediction and prevention. Well, we all managed cases day in and out, and there's not much to say about management. But here I would like to stress on some salient points which would be useful for all of us. I begin with this beautiful quote: successful mothers are not the ones who have never struggled. They are the ones who never give up despite the struggles. Well, motherhood begins with the onset of pregnancy, and a woman with having hypertensive disorder of pregnancy, it's a struggle for her. The struggle to maintain her blood pressure, to have her child at 37 weeks. If you look at the incidence, it affects 1 in 10 women. a blood pressure of 140/90 or more. In 20% cases, it is pre-existing. It means chronic hypertension was existing before pregnancy. In 80%, it is de novo gestational hypertension or preeclampsia. It is the commonest medical disorder, and we all know it complicates 10 to 15% of all our pregnancies, preeclampsia, and 3 to 5%, and more so in preemies, 10%. In our country, the incidence of eclampsia is also very high, 1%. And so HDPs are leading cause of maternal morbidity and mortalities. Preeclampsia is a common cause of iatrogenic prematurity. But as it has been stressed, antenatal care, especially in the second half of pregnancy, must be largely geared towards detection of hypertension and preeclampsia. These are the various complications associated with preeclampsia. Short-term complications, maternal and fetal, like risk of seizures, pulmonary edema, placental abruption, oligo, and FGR. Then it has implications in adult life also, because offspring of affected pregnancies have an increased risk of stroke. Long-term cardiovascular morbidity and mortality is also there in these women, like development of hypertension, more chances of myocardial infarction, major cardiovascular events increase 13-fold, heart failure, stroke, and death. First, the definitions. This was the definition given by ISSHP, the recent classification. Hypertension known before pregnancy or present before 20 weeks, chronic hypertension, which could be essential secondary, white coat hypertension, and mask hypertension. Then hypertension arising de novo at or after 20 weeks, transient gestational hypertension, and preeclampsia. Now, they've not further labeled it into mild, moderate, or severe, or mild and severe as we usually label it, but still it could be de novo or it could be superimposed on chronic hypertension. These are the causes of secondary chronic hypertension, which we all know. The diagnosis of preeclampsia, systolic blood pressure more than 140/100, or a diastolic blood pressure more than or equal to 90 mm at least 2 occasions, 4 hours apart after 20 weeks of gestation. Plus these factors, either proteinuria, low platelet count, rise in serum creatinine, liver transaminases, pulmonary edema, or at times visual symptoms. When these symptoms are present, it is considered to be severe hypertension. Now, in 2013, ACOG removed proteinuria as an essential criteria for diagnosis of preeclampsia. They also removed massive proteinuria. Oliguria was also removed, but ISSP has included FGR to consider in the diagnosis of preeclampsia. So a woman with preeclampsia, that means a BP more than 140/90, if she has all these features, then she's labeled as a case of severe preeclampsia. Systolic blood pressure more than 160/100, symptoms of CNS dysfunction, hepatic abnormality, thrombocytopenia, renal abnormality, and pulmonary edema. So when these are present, at times we see that blood pressure is a bit low. Still, these features are present. Then we would label her as a case of severe preeclampsia, and she would require, of course, prophylactic Maxil therapy. The typical presentation we all know is a rise in blood pressure. And then if it is severe, all these signs. But here I would like to mention atypical presentation of preeclampsia. Atypical preeclampsia syndrome, as it is called. Here they have labeled 5 categories. In the first category, only gestational hypertension with features of hemolysis or altered lab tests. Then only gestational proteinuria with any feature of hemolysis or altered lab test. So it means that only proteinuria is present and there's no hypertension. Hypertension, her blood pressure could be mildly elevated. It could not be elevated. Still, these women have to be monitored carefully because they may develop typical preeclampsia after a few days or after a few months also. Then there's a condition, capillary leak syndrome, in which she has edema all over, including the presence of pleural effusion. So these cases also are cases of atypical preeclampsia syndrome. Early signs and symptoms of preeclampsia, that is less than 20 weeks. Late postpartum eclampsia, that is more than 48 hours after delivery, but less than 4 weeks. So these too early and too late are also atypical preeclampsias. Evaluation.
In addition to her blood pressure, all these tests, like a complete blood count with platelets, serum creatinine, liver chemistries, urinary protein determination, are essential. At times, we do require coagulation studies, upper abdominal epigastric pain, or severe liver dysfunction. In these cases, we have to rule out other causes. So glucose, amylase, lipase, and ammonia levels also have to be done, and assessment of fetal status. Now, we have seen some cases in which they have severe headache, which does not respond to routine analgesics. In those cases, we should consider an MRI. And if she complains that she has severe headache, a worst headache of my life, and is not responding to any analgesic, it could be a case of subarachnoid hemorrhage and would require neurology consultation and detailed imaging. Measurement of angiogenic factors does help, but we do not have them. S-FILT and placental growth factor ratio is important in identifying preeclampsia from other causes. The most important thing is the measurement of blood pressure. Measurement of blood pressure, these guidelines always use accurate equipment, use it in sitting or semi-reclining position. The arm should be at the level of the heart. Appropriate cuff height should be there. Deflate the cuff slowly. Use Korotkov 5 disappearance as measurement of diastolic blood pressure. Measure to nearest 2 mm, etc. Manual sphygmomanometers should be used to establish baseline BPs as a reference for automated monitoring in hospital for women with preeclampsia, unless the automated system has been validated. So at times, the automated system is also not good. So manual sphygmomanometers also should be available. One important point I would like to stress here is that her baseline BP should be known. In various guidelines, criteria have been mentioned, like a rise in systolic BP by 30 mm or rise in diastolic BP by 20 mm also signals the presence of preeclampsia if other factors are present. So in these women, like if she has a blood pressure of 100 by 60, a blood pressure of 130 by 90 could also be preeclampsia if she has all other features also. At times, we see women who are having a blood pressure of 130/90 convulsing. So it may be that her baseline blood pressure was quite low and she does have preeclampsia. So measuring the baseline blood pressure at the onset of pregnancy is very important. It should be done properly and it should be very well documented. So before management, the various drugs we should know. Labetalol is the first line therapy, 100, and the doses are very important. Sometimes people give only 100 milligram once a day, or they give 50 milligram twice a day, but that is not the accurate dose. Labetalol first line 100 milligram BT, maximum dose could be 500 milligram QDS, and asthma is a contraindication to its use. The second line is nifedipine, slow release, 10 mg twice a day. It could be maximum dose 40 mg twice a day. Methyl dopa is being used still in our country. Third line dose, 250 mg BID, 1 gram TDS is the maximum dose, but it should never be used in cases of depression, and postnatally it is not advisable. Other drugs like hydrazine is not available. Women who are on ACE inhibitors, cases of chronic hypertension, these medications should be stopped and they can only be given in pregnancy. In postpartum, they should not be given in pregnancy. Now, sometimes women come with acute rise in blood pressure, like more than 160, 100, 170, 180. At times, we see women with 200 blood pressure. In those cases, two basic drugs which are to be used are labetalol and hydralazine. Hydralazine as such was available previously, but we do not have any such, we do not have it now. Labetalol 20 mg IV, gradually over 2 minutes, repeat blood pressure at 10 minutes. If BP remains above target level, give 40 mg, then again measure it at 10 minutes, 80 mg, again 80 mg. This is how we have to titrate the level. And then start a continuous infusion of 1 to 2 milligram per minute instead of intermittent therapy after 20 milligram IV dose. So we can give both things, 20 mg, and then gradually go on increasing it, or start it at 1 to 2 milligram per minute and keep it at that level. So if you find that her blood pressure is controlled with 80 milligram, then that dose has to be maintained till her blood pressure or till she delivers, till everything comes back to normal. Now, at places we may not have labetalol or we may not have hydralazine. In those cases, it has been recommended that nifedipine extended release tablets 30 mg orally can be given. If blood pressure target is not achieved in 1 to 2 hours, then another dose can be given. At places they have nicardipine parenteral injections that also can be used. And nifedipine immediate release can be used, but it should be used with caution because it causes a sudden drop in blood pressure. If you want to use it, you can use it 10 milligram orally and then see what change occurs and have a constant monitoring. In all such cases in which they come with a raised blood pressure, they are admitted in the hospital, measure blood pressure every 15 minutes, urine output hourly using an indwelling catheter, oxygen saturation. Fluid balance is very important in these cases. Respiratory rate should be measured hourly, temperature 4 hourly. Sometimes the veins are collapsed and we may have CVP and arterial lines. Then continuous charting of blood pressure is done according to them. In all such cases, fetal well-being should be assessed carefully, and you can put a CTG, continuous CTG monitoring, or you can do a growth scan for assessment, Leica assessment, and umbilical artery Doppler. Careful fluid management is important. Fluid balance is aimed at avoiding overload. Total input should be limited to 80 ml per hour. If oxytocin used, then it should be used in high concentration so that excessive fluid is not given. Oliguria should not precipitate any specific intervention and should encourage early delivery. These are the protocols according to NICE guidelines. Here they have mild, moderate, and severe categories, but for us it is mild and severe category alone. In mild preeclampsia, admission to the hospital if BP is more no admission is required, but admission to the hospital if BP is more than 150/100. Between 140/90 and 150/100, patient can be monitored as outpatient. But if it can be monitored inpatient, before 140/90, it is to be monitored as outpatient. So when we get women who have their blood pressures 140/80, 130/90, in those cases, only follow-up visits and continuous monitoring at regular visits is important. However, if mild blood pressure elevation is there, in those cases, you do not have to treat. But if it is more than 150/100, oral labetalol is the first line treatment. Measure blood pressure 4 times a day, test for proteinuria. Quantification is to be done once only. Every day, you do not have to do a urine protein level. Blood tests are essential. Monitor twice a week. Kidney function test, bilirubin, electrolyte, full blood count, and transaminases for mild hypertension. But monitor them 3 times a week if there is moderate or severe preeclampsia. Fetal assessment. For mild cases, offer fetal auscultation at every antenatal appointment, carry out ultrasound assessment of the fetus at diagnosis, repeat every 2 weeks, carry out a CTG at diagnosis, and then only if clinically indicated. Offer fetal heart rate at every antenatal visit, an ultrasound assessment, and it must be repeated whenever required. Regarding timing of birth, if she has severe preeclampsia, less than 34 weeks of gestation, for severe preeclampsia, termination of pregnancy is the mode. But for mild hypertension, we can consider continuation of pregnancy till 37 weeks or till severe signs and symptoms occur. So before 34 weeks, continue surveillance unless there are indications or unless there are signs of severe preeclampsia. Offer intravenous magnesium sulfate, antenatal corticosteroids if severe symptoms develop. And then consider delivery. From 34 to 36 weeks, again, continue surveillance. And when considering the option for planned early birth, take in account the woman's and baby's condition, consider the risk factors, availability of neonatal units, consider a course of antenatal steroids. Whenever you find a woman who is 37 weeks or beyond and having a raised blood pressure, initiate birth within 24 to 48 hours. So delivery in all such cases should be individualized, depending on her blood pressure, depending on her repeated tests. Plan delivery on the best day in the best way. It should be planned, the best possible route, and the best support team. The timing affects the outcome of the mother and baby. If the mother is unstable, then delivery is inappropriate. Like in a case of eclampsia, first we need to stabilize the mother and then consider the option of induction or a cesarean section. Record maternal and fetal thresholds for planned early delivery before 37 weeks. Thresholds for considering planned early birth could be inability to control blood pressure, despite using antihypertensives in appropriate doses, maternal pulse oximetry less than 90%, progressive deterioration in liver function, renal function, hemolysis or platelet count, ongoing neurological features like intractable headache, repeat visual disturbances, eclampsia, placental abruption, reversed end diastolic flow, or abnormal CTG or stillbirth. So when you are monitoring the woman and any of these signs are present, that is an indication of immediate termination of pregnancy. In all such cases, always involve a senior obstetrician, discuss with the anesthetic team, discuss with the neonatal team, and in cases of severe preeclampsia, offer intravenous magnesium sulfate and a course of antenatal steroids. In the early postpartum period, when women, they still should be considered at risk for complications at least for 3 days, and they should have their clinical condition monitored every 4 hours. And antihypertensive should be continued if her blood pressure is not within the range, and they should be gradually withdrawn slowly over days, but not abruptly. It is important to note eclamptic seizures may develop for the first time in the postpartum period as well, and therefore monitoring is important. Avoid NSAIDs for postpartum analgesia and preeclampsia because they may precipitate AKI. One such complication of preeclampsia, which is common, is eclampsia. This is the chart, and this chart should be there in each and every labor room or in eclampsia ward for appropriate management. Whenever a woman starts developing convulsions, even though if we do not know her blood pressure, we think her as it is labeled as a case of eclampsia. And in all such cases, do not leave the patient alone. Airway, breathing, and circulation, ABC of resuscitation has to be started. Then comes control of seizures with appropriate dose of magnesium sulfate. If her blood pressure is raised, start antihypertensives. If she's not postpartum, once she's stabilized, consider for delivery. Delivery is always a team effort, but after stabilization of the women. And at the same time, various observations have to be taken and investigations have to be sent. Some salient points regarding eclampsia: at times, women have altered renal function tests. In those cases, always go for the low-dose MaxSulf regime. And sometimes, in spite of giving magnesium sulfate in appropriate dose and then again giving a 2-gram dose, still convulsions do not subside. In those cases, we can use any of these drugs: lorazepam 2 to 4 milligram IV, diazepam 5 to 10 mg IV every 5 to 10 minutes, maximum dose 30 minutes. Phenytoin we were using continuously, 15 to 20 milligram per kg. So in addition to MaxSulf, phenytoin can be added, or nowadays we use levetiracetam 50 mg IV and may repeat in 12 hours. So for recurrent convulsions, in spite of using MaxSulf, these are the drugs which can be given. Now the other complications like HELLP syndrome, pulmonary edema, hemolytic uremic syndrome, they have to be managed in an ICU in consultation with a multidisciplinary team. Like we need an intensivist, we need a physician, a respiratory physician as well to monitor these patients, and delivery at the proper time is the main thing. After she delivers, her condition may improve. There are cases of chronic hypertension in which pre-pregnancy she has been diagnosed with a raised blood pressure. They are associated with adverse maternal fetal outcomes like stroke, low birth weight, neonatal unit admission. For them, aim for tight BP control, fetal growth monitoring, repeated assessment for development of preeclampsia and maternal complications. Such women can be managed on an outpatient setting, but then they may develop superimposed preeclampsia. So always look for signs of preeclampsia. It should always be a consultant-led care. Stop antihypertensive treatments for those who are already taking ACE inhibitors or ARVs and offer alternative treatment. So instead of the drugs which she's taken, we can start her on labetalol. Labetalol, nifedipine, and methyl dopa are now specified as suitable. According to new guidance, tight BP control 135 to 85 by 85 is the rule of a treatment if not already on antihypertensive if her blood pressure is more than 140/90. In all such cases, if she comes early before 12 weeks of gestation, offer her 150 milligrams aspirin. PIGF test can be done. Now, she's already hypertensive. We are doing PIGF test to identify the development of preeclampsia. Lifestyle advice, weight management, exercise, diet, reducing salt intake may help. Weekly appointments if blood pressure is poorly controlled, 2 to 4 weekly appointments if blood pressure is controlled. Timing of birth is agreed in partnership if more than 34 weeks and BP is maintained below 160/110 with or without treatment. So essentially all cases of preeclampsia by 37 weeks, fetal lung maturity does occur and they need to be developed, they need to be delivered so that complications do not develop. Then about recurrence. So once she's had preeclampsia or once she's had a bad outcome in her previous pregnancy, she may have it in the subsequent pregnancy as well. So in these cases, the main essence is on prevention by giving low dose aspirin by 12 weeks of pregnancy, and for preeclampsia, they have identified the dose of 150 milligrams. If she's too low her body weight is too low, then in those cases, we can give 75 or 100 milligrams. Preeclampsia increases risk for subsequent hypertension 2 to 5-fold, cardiovascular disease 2-fold, cerebral vascular disease 2 to 3-fold. These risks are also higher with early onset preeclampsia and FGR. Preeclampsia and cardiovascular disease may share many of the same risk factors and pathological changes, including widespread endothelial damage, dysfunction, and increased systemic inflammatory response. Thus, women who have suffered preeclampsia are candidates for CVD screening and possible intervention. So in next pregnancy, they are definitely high risk, but in their future life also, they are at risk for cardiovascular diseases. So depending on the time when her previous delivery occurred, she could, if previously she delivered between 28 to 28 weeks, the recurrence risk is 40%. 28 to 34 weeks, recurrence risk is 33%. 34 to 37 weeks, 23, and 37 plus weeks, the recurrence risk of preeclampsia in next pregnancy is only 10%. So if she's had a preterm delivery at a lower gestation, she's had eclampsia, she's at a very high risk in her subsequent pregnancy. This should be kept in mind. Now, these are a few patient information leaflets. I know they are in English, but we do have urban patients as well who may understand English, and we can convert this into Hindi. And what I feel now is that once we have identified a woman as having a raised blood pressure, we should counsel her. Unless and until we counsel her properly, we show her some data, she would not be counseled about the early termination, or she would not know about the risk, and they again come up in a bad situation. So these are patient information leaflets. They can be converted into Hindi, and they can be given to all patients who are having a raised blood pressure. These are about the risks, and this is about the medicines which are usually given in pregnancy for preeclampsia. A mother is she who can take place of all others, but whose place no one else can take. So we must save all these mothers who are having preeclampsia. We must try to save them. And we should always have a healthy mother and a healthy baby. Thank you.
Thank you, ma'am, for such a crisp, clear, succinct, and comprehensive talk. Please excuse me, I have a very bad throat today. So it was very wonderful to go through the entire lecture. You took us very nicely through all the steps. So you actually got all the nichod in this talk. You know, Ketana, all the nichod was there. So as always, it was an honor listening to you, and I loved the talk. Wonderful presentation.
Thank you. Thank
Ruby,
you.
ma'am. Ma'am, you need to unmute yourself.
Thank you, madam. Your presentation was really very excellent. You made this complex topic so clearly. And as you rightly said, the guideline of BP measurement, as in our OPDs, our staff used to measure BP. So we have to explain them the guidelines. because the whole treatment is dependent on the BP measurement. And you tell about the fluid balancing, which is very important. And before delivery, we have to stabilize the patient. And I just want to add few points. Yes, fourth trimester follow-up is very important. Fourth trimester means after delivery up to 12-week postpartum. This is very important. And SDP is associated with increased risk of future cardiovascular diseases. So these women should be monitored for long-term health issues. Thank you, Sneha ma'am, for making me part of this webinar, and all the best for your election. Ab ki baar really 4,000 par. Thank you, ma'am.
Thank you, Ruby ma'am, and thank you, Aditi ma'am, for sharing the session. Thank you, Anupama ma'am, for being and accepting our invitation and presenting such an elaborate talk so that all our delegates have such a wonderful take-home messages. Both our speakers have done justice to their talks. Even if we are able to reduce at least one maternal mortality in our setups, then the purpose of doing these webinars will serve. Let us now move forward to the next academic session, that is the panel discussion, which will be moderated by Dr. Sneha Bhuyar Madam. Our experts for today, Dr. Padma Shukla Madam and Dr. Sunita Wadhwani Madam. Madam has already been introduced earlier, that is why we will move on to the next. Dr. Padma Shukla Madam is the president of the Reva OBGY Society. She has just finished a very successful conference. She has received many awards, including the Jagdeshwari Mishra Prize, the C.S. John Award, the Foxy Young Talent Award, the Foxy Achievers Award, and the D.C. Gupta Prize for the Best Publication in 2023. She has also received many distinguished society awards, including the Durusha Award, the Mailan Smriti Award, and the Chitrahara and Gangadharan Preventive Oncology Award, the IFS Sukanya Award. We welcome you, ma'am. Our next expert for today, Dr. Sunita Wadhwani Madam, is the president of the Ratlam OBGY Society, director and consultant at Ratlam Hospital and Research Center. She's an NABH certified assessor, and she has done an MBA in hospital and healthcare. Her special interest includes critical obstetrics, and she's a lead assessor and master trainer at Manyata by Foxy. We welcome you, ma'am. Our panelist, Dr. Jagrati Madam, is the past president of the Sagar OBGY Society. She is the associate professor in the department of BMC Sagar, the organizing committee of AMPOGS at Sagar Society in 2016, and she has several publications to her credit. We welcome you, ma'am. Our next panelist for today, Dr. Dolly Mehra Madam, is a consultant at Mehra Nursing Home at Ratlam. She's been the past president of the Ratlam OBGY Society, the organizing chairperson of the MP State Conference at 2018, the zonal coordinator for Foxy 19 to 20, the joint secretary of AMPOGS 2019 till present. She has received various awards, including the Durusha Youth Trophy for Best Activities in Adolescent Health, and she's been felicitated by the Health Minister of MP for providing services under PMSA Scheme 2019. We welcome you, ma'am. Our next panelist for today, Dr. Neha Saraf Madam, is the secretary of the Ratlam OBGY Society and consultant at Ankur Hospital. We welcome you, ma'am. Our next panelist is Dr. Sonal Agarwal Madam. She's an associate professor at Shamsa Medical College, Rewa. She has published various papers, including the risk factor analysis for cases of ectopic pregnancy, which was an observational study. She has written many chapters, and she has been elected as the Joint Secretary for Reva OBGY Society for the year 23-24. We welcome you, ma'am. Dr. Nidhi Bajaj Madam is a director at Sparsh Multi-Speciality Hospital and the Secretary of the Katni OBGY Society. She has publications including the term uterus and complicated ventral hernia to her credit. She is a part of many professional bodies, and she has done a lot of social activities. We welcome you, ma'am. Dr. Swati Patel Madam is the director at Kalyanika Hospital, Sagar at Madhya Pradesh. She is the treasurer of the Jabalpur OBGY Society from 2014 to 16, the joint secretary from 16 to 18. Her special interests include high-risk pregnancy and vaginal hysterectomies. Our next panelist for today, Dr. Mohita Pandey Madam, is a demonstrator and a senior resident in the Department of OBG, SMSC Reva. She has received the DC Datta Award. She has also had gold medal in MBBS and MS, and she has certificate of honors in almost 11 subjects. She's an co-editor of the Jagriti publication for the year 21-23. We welcome you, ma'am. Dr. Rekha Singhal is the secretary of the Reva OBGYN Society. Sneha, ma'am.
Yes,
Yes,
thank you
ma'am.
so much, Monica.
Over to you, ma'am.
Yes. Thank you so much, Monica. I hope you can hear me.
Yes, ma'am.
Hear me? Yes. So very good evening to all of you. And I congratulate Dr. Binu and Dr. Anupama Dave and thank them for the wonderful, speeches they have given. Without much ado, we would like to go ahead with the panel discussion. So I'm very happy to have all the esteemed panelists, Dr. Jagrati, Dr. Dolly, Dr. Neha, Sonal, Nidhi, Dr. Swati Patel, and Mohita Pandey and Dr. Rekha Singhal. I think there's a typo mistake. Please forgive me. So with this, and we have of our expert, Dr. Padma Shukla, and Dr. Sunita Vadhani. So I'm very happy to welcome all of you. We just start with our panel discussion without much ado. So friends, all of you know that I have been already talking to you that, hypertension, hemorrhage and sepsis, these are the three major killers of women. And in spite of having so many predictive factors, so many predictive tests, may it be biophysical or biochemical, we are still not up to the mark. There's not significant reduction in the maternal morbidity and mortality. So friends, it's a time that we should, always be prepared for prediction, prevention, as well as, preparedness for any emergency or any situation that may come to you. So today's topic of discussion is hyperglycemia in pregnancy. And all of you know that it's not a matter of pride that, India is considered as the capital of diabetes. So friends, the population of diabetes per se is growing. May it be type 1, type 2 or gestational diabetes. Almost 60 million women of reproductive age group worldwide, they have diabetes mellitus, and this will double by 2030. That is what is the estimated, and that's a matter of concern. At least 40% of these diabetic pregnancies are unplanned, and you know what happens if the pregnancy is unplanned. So gestational diabetes mellitus is actually, it is a carbohydrate intolerance, glucose intolerance, which is actually recognized or diagnosed for the first time during pregnancy. It may or may not exist before the pregnancy. So this is just the statistics. I don't want to bombard with you all this, but 2 out of every 5 women with diabetes are of reproductive age group, and they account for almost 60 million women worldwide. The prevalence of hyperglycemia in pregnancy increases rapidly with age and is highest in women over the age of 45. These are some facts which I wanted to share with you. So, Dr. Jagrati, let us just discuss this. What is the impact of hyperglycemia in pregnancy on perinatal and maternal outcome? And why are we worried so much about this hyperglycemia in pregnancy? Yes, Dr. Jagrati. I think may I request all of you to please put on your videos, at least the panelists. Hello. I can see Dr. Neha. Hi, Neha.
Hi, ma'am. Good evening,
Hi.
ma'am.
Good evening. Good evening, dear. And I don't see Dr. Dolly.
I'm there, madam. I'm not putting on my video because I'm traveling and the signals are not very good.
No problem. No problem, dear. But I'm happy to have you. Do we have Dr. Jagrati? No. Okay. So can we go ahead with the discussion? Dr. Neha, what is the impact of this HIP on perinatal outcome, and why are we worried so much about HIP?
Ma'am, of course, hyperglycemia in pregnancy have a lot of impact both on the mother and the fetus as well. We can label these impacts as short-term and long-term impacts.
Yeah.
The short-term impacts include the maternal morbidity and mortality due to complications like macrosomia, then PPH, then hypertensive disorders,
Right.
obstructed labor and all. And
Right.
there is a high likelihood of preterm births. The long-term impacts are there is an increased risk of the patient having diabetes in her later life, like she's
Right.
will be a diabetic for life.
Yes.
And there is a chance of recurrence in subsequent pregnancies as well.
Right. And what about the baby?
And the baby will have macrosomia, so the baby might go into hypoglycemia at birth, and later the baby is also at risk of developing diabetes.
Right. You're very true. You have already discussed that about only thing is about 50% of these women may land turn out to be the type 2 diabetes over the down the period, maybe 5 years onwards. And the baby or the baby who is born has a risk of developing metabolic syndrome or type 2 diabetes in the future. Okay. So Dr. Dolly, we come to you straightway. We have this Mrs. C, 22-year-old primary gravida, and she's coming to you for first antenatal checkup at 10 weeks of gestation. On examination, she's 152 centimeter tall, weighs I just see how much 69 kg, and BMI is 30 kg per meter square. She does not have any family history of diabetes. Would you like to screen her? If yes, how?
Thank you so much, ma'am, for giving me the opportunity. Yes, I would like to screen this patient because there are certain high risk groups wherein we need the screening. So the high risk groups are a BMI more than 30. It is borderline over here, 30 kg per meter square. A
Okay.
family history of diabetes, previous history of gestational diabetes. Then ethnic groups, like we are into that Asian ethnic group, which are more prone to diabetes. So definitely, I would like to check this patient for GDM or for diabetes early in the pregnancy. As
Okay.
such, we do the testing at around 24 to 28 weeks. But in India, we say that it should be done on booking as well as around 22 to 24 weeks
Yeah.
or 24 to 28 weeks.
Yes. So, Dr. Dolly, your first part of the answer, I fully agree that yes, you must screen these women. Okay. But the second part, we will little modify. Gone are the days when we used to do screening only for high risk patients, the women above 35 years age about the women about 35 years, obese women, those with family history, and those with PCOS. Okay, these were the women who used to call it as high risk women, and we used to screen that. We used to label this type of screening as risk screening. Okay, but nowadays there is a concept of what is called as universal screening. That means every woman should be screened during every pregnancy. Okay, and that is how we have to screen these women universally. Now, coming to the, when you have already answered the question that when you should screen. First is at the first antenatal checkup, and second is between 24 to 28 weeks. Now, what screening test is to be used, Dr. Dolly?
So it is basically a glucose screening test wherein we give 75 grams of glucose load to the patient, regardless of her status of the food, and then we do a sugar level at after 2 hours. So this is a plain, simple capillary blood that we check for these patients, and they are instructed not to eat anything in between these 2 hours. They can drink water, they should take rest, and you have to check at 2 hours after giving a 75 grams of glucose load.
Okay, okay. So how do you interpret? You're very correct that you have done this where she did not be kneel by mouth, and irrespective of the timing of her previous meal, she can undergo this testing. You just ask her to drink this 75 gram of glucose. So how do you do this practically?
So if it is more than 140, then we label
So how do
her
you
as
do this
GD.
test? How do you do this
No,
test?
it is done by a glucometer by your own staff in
Yeah,
the
yeah,
OPD by the capillary blood. So
yeah,
it is not that you have to use a venous blood or something else.
yeah,
Just by glucometer, you can do a capillary blood screening, and
agree.
it should be less than 140, not
Yes,
more than 140. If it is more than 140, we label her as a case of GDM
agree.
or diabetes accordingly. And if it is less than 140, it's fine. So
Yeah, yeah.
now,
That you're talking about interpretation. Agreed with your interpretation. What I'm trying to ask you is how should you perform this test? When should she drink? How much sugar and how
okay,
much water
so
she should drink?
it is around 75 grams of glucose and around 100, 200
200.
ml of water, a glass of water
Yeah.
to be taken over a period of 10 to 15 minutes. The time should be noted, and exact at 2 hours, the capillary blood has to be measured.
Okay. Okay, right. So Neha, suppose your patient has, consumed this glass or 200 ml of water, dissolved, the glucose dissolved in that, and she has consumed it comfortably, but suddenly she vomits out. So whether you would like to go ahead with the test or how?
Ma'am, yes, I would like to get the test repeat done, but after a few days, say next day or.
Yeah. So if she
Yeah,
vomits,
I would like to differ. If she
yeah,
vomits within 30 minutes of
yes,
intake of glucose, then it has to be repeated. If
yeah.
she vomits after 30 minutes, then you can go ahead with the test.
Perfect. So that is what I said, that if she vomits immediately. So if she vomits after half an hour of consumption of this glucose, water or glucose solution, then we can definitely go ahead with the continuation of the test. How do you interpret, Dr. Sonal? How do you interpret this?
Thank you for the opportunity, ma'am. GTT interpretation is very simple. We need only a single value. And if this value comes below 140 milligram per deciliter, we consider it as non-diabetic.
Okay.
If it comes between 140 to 200, we will consider it as a risk for diabetes. And above 200, it's a overt diabetes. So 140 to 200, we will give diet maintenance and continue management.
No,
And
we will
we
come
will
to that.
repeat screening as advised.
We'll come to that. Sorry, I just want to interrupt you because yes, you said more than 140, she is screen positive, right?
Yes.
So
Yes.
what about the one who is, in between 120 to 139? What do you label them?
Pardon, ma'am, I can't hear you. What's the question, ma'am?
Blood sugar level after 2 hours, if it comes anything between 120 to 139.
Still, ma'am, we will advise a healthy diet and we will keep on screening as advised by DIPS at 28 weeks and 32 weeks.
Okay, so this type of patient is called, result is called as gestational glucose intolerance or impairment, GGI. Okay, gestational glucose impairment. And this is a lady who is at risk of development of GDM. That is why when you do the subsequent testing at 24 to 28 weeks, you may have that, she can come positive. Okay.
Yes, yes.
So that's a very, yeah. So you have to just keep it in mind. So, Dr. Nidhi, this is a question for you. We have this Mrs. C. She has her fasting blood sugar level done, and results are fasting blood sugar level 86 milligram percent, HbA1c 5.6%. So, does she have diabetes, Dr. Nidhi? Do we have Dr. Nidhi? If no, please somebody can take up this question.
No, ma'am, she doesn't have diabetes. She's perfect. Her reports are perfectly normal.
Okay.
Fasting sugar 86.
Okay. Does she have GDM?
Ma'am, for that, I would like to go for an OGTT. I
That is
cannot
what.
label her by
Yeah.
this test.
Okay. So does she need to be tested again? Yes, definitely. We should test her because for screening of GDM, it is the OGCT, oral glucose challenge test, that needs to be done and not the fasting one. Okay. Okay.
Yes.
Now, suppose your patient has come screen positive. How do you go ahead with the management?
The management includes both healthy lifestyle, diet control, exercise, walking, and then
what is
but
it called as? What is it called
actually
as?
management includes it depends on the level of blood sugar which is reported after OGTT. If the sugar levels are on the higher side, say more than 200, then we have to start medical therapy like oral hypoglycemics or insulin therapy. If it is a borderline raise, then we can go with the general management first, the medical nutritional therapy and the exercise and diet control and all that. And then we can keep her screening every 2 weeks.
Okay. Yeah, so medical nutrition therapy includes what?
It includes diet control.
Includes diet modification and active physical exercise. You tell me about diet modification. What modification she should make and how? Because every city doesn't have a nutritionist or dietitian. So we obstetrician have to have that much knowledge minimum knowledge to explain them what is medical nutrition therapy. What she should consume. What is
Ma'am,
actually,
I would like to advise her to have a plate of non-starchy vegetables with more of proteins and less of carbohydrates.
Yeah, before that,
three major and three minor meals are actually the meal is to be divided over 24 hours. Three major and three snacks are allowed. And then this plate method, that is 50% of the non-starchy vegetable, 50% of the cook, and have a thumb impression of fats. So that is for the lunch. And ma'am, exercise is something which is to be taken up after 45 minutes when the plasma glucose starts peaking, and 30 minutes of the isometric exercises like walking, and walking at a rate where the patient is not uncomfortable to talk with a fellow passenger, but at least her pulse rate rises. So these are few things. And medical nutrition therapy, total actually the calorie intake is according to the activity level of the patient.
That is what I wanted to say. Make it very simple.
Sedentary है, moderate है.
हाँ.
उसके हिसाब से.
Basically, you have to know she should consume how many calories. So how many and what? Okay.
What?
That you have to know. So how many? How do you calculate that?
मैम एक मतलब रफ गाइडेंस के लिए है कि आफ्टर 18 यू बिकम अ मदर, तो 1800 से शुरू करना है और 2800 तक जाना है, और बीच का पॉइंट है 2400. तो फॉर पर्पस ऑफ रिमेनिंग आई हैव मेड इट इन माय माइंड. फॉर सेडेंटरी लाइफस्टाइल इट इज 1800 किलो कैलोरी. For heavy workers, it is 2800, and for moderate worker, it will be between 2400. That is the basic requirement of a woman. Additionally, 300 in pregnancy I add. तो 1800 से 2800 और बीच का एक पॉइंट 2400 ले लिया था फॉर द पर्पस ऑफ रिमेम्बरेंस ओनली. एंड आउट ऑफ दिस किलो कैलोरीज majority will be given at the breakfast.
Correct.
And most of the calories will be by the non-complex carbohydrates.
Yes, perfect.
Then protein.
Okay. So basically your daily requirement, caloric requirement is, decided by your baseline weight. Okay. Pre-pregnancy or early pregnancy weight. And then how much weight gain you should achieve or you are allowed to achieve. Okay. Whether your level of activity is sedentary, moderate or heavy, that will all decide how much calories you should consume. And then comes the right quantity and right quality. And in quality, you have already discussed that, how you say the plate method. So maximum, usually, normally, routinely, we do 50 to 60% of carbohydrates. For this lady, 40 to 50% of carbohydrates. And then rest proteins and fats, as you have already said. So that is all about the diet. What about exercise? What exercise you want to do for this lady? What exercise you want to advise for her?
I advise them simple walk of around 30 minutes in the morning and evening.
Okay. Do we have our experts here, Dr. Sunita and Dr. Padma? Have they not joined? Yes, yes.
Good evening, madam, and thank you for the opportunity, ma'am.
My pleasure, please. Yeah, go ahead.
Madam, I would advise them to walk after their meal. At least they should walk for 20 to 25 minutes after their major meals.
Okay.
And walking is a good exercise, and as well as upper body exercise we can advise for the patient.
Yes. Stretching exercises.
Stretching exercise.
So very good. So provided there is no obstetric complication, provided there is no medical contraindication, we can advise the pregnant lady with moderate exercise of at least 30 minutes a day for 5 days a week. Maybe weekends you can give Saturday, Sunday free, but that should be enough. 150 minutes in a week. Okay. So 30 minutes per day, Neha, as you have rightly said, all of you have said that, but just to put it in simple words, half an hour daily for 5 days. Okay. Moderate exercise. Maybe the routine walking and the household work, especially dusting and, all these things. And then, of course, stretching exercises, as doctor, you have already said. So, diet modification and active physical exercise, this comprises of medical nutrition therapy. Okay. So, simple thing is, whenever your patient comes to you, and if she's GDM positive, you give her 2 weeks time. Don't it is only GDM positive. I'm not talking about over diabetes. Okay. GDM screen positive, give her 2 weeks time, advise her MNT, and of course, after 2 weeks, how do you test her now, Dr. Swati? Dr. Swati, do we have, can somebody inform me how many panelists do we have? I can see Neha and Dolly, and madam, if you can please let me know who else.
Dr. Mohita, madam.
Mohita, yes. I think, yeah, if somebody can rename, that could have been better. Okay, Dr. Mohita. So, Dr. Mohita, can you please throw some light on this? When do you test her again? That is, I told you after 2 weeks. Yeah. So, what you want to do? What test you want to do after 2 weeks?
Ma'am, I would like to go for blood sugar fasting and PP in that case. After 14 weeks at least.
2 weeks later, it is recommended that you should go for only 2 hours postprandial. Okay.
Okay.
You can go, that is a routine. But what is recommended according to this OGCT, or what is called as DIPSI? Okay. DIPSI is itself an organization which has its guidelines. Foxy ICOG, NHM, FIGO, everybody agrees to these guidelines. And that is why it is very important for all of us. Okay. So 2 hours postprandial. Okay. So how much it should be? 2 hours postprandial. How do you say that, MNT has helped? Yes, anybody can take up this question.
Less than 140?
No, my dear. Less than 120. Okay. As we have said, screen positive is 140. Okay. But then for 2 hours postprandial, that is after 2 weeks, it should be less than 120. I think please write it down. It should always be less than 120. Then you mean to say that, the MNT has helped her. So you ask her to continue with the same lifestyle. This is your diet and this is your lifestyle. Please do continue with the same till you deliver, and then later on we'll talk. Okay, that is how. Now, we have talked about when will you review, and suppose you do her HbA1c, because for the prognosis, and you find that her HbA1c, say already I have displayed. If her HbA1c is more than 10, Dr. Mohita, what will you advise your patient?
Ma'am, till she has a HbA1c under control, that is less than 5.6, I would advise her not to become pregnant, because such high levels will lead to increased level of malformation in fetuses. HbA1c has got no value in managing GDM or over diabetes mellitus in pregnant patients, but it has a very good predictive.
No. My question is, suppose you diagnose her as GDM, you do her HbA1c, and because she is diagnosed for the first time, her HbA1c is more than 10. What does it mean, and how will you counsel the patient? That is the question.
Ma'am, that patient should be subjected to anomaly scan at the earliest, because there are high chances of anomaly, because for the past 3 months her sugar have been raised. So that patient, for I will go for screening about the fetal anomalies.
Okay. So
as per the weeks of the gestation.
Yeah, to clarify further, see, if the HbA1c is more than 10, the rate of malformation is as high as 31%. 31%, very high. Okay, so you have an opportunity to counsel to that lady or that couple, saying that the chance for anomalies is very high. So they have to get screened for all the biophysical and biochemical tests possible, because 31% is really very high. That you are not supposed to advise her for MTP at this point of time. Okay. You have to just counsel that they should get screened and rule out all the abnormalities, whether it is chromosomal aberrations or even the congenital malformation. Okay, that is what is the this
Can I
slide set.
add something over here, ma'am? You
Yeah,
know,
yeah,
if
please.
if the patient is diabetic, you are going to do the glycosylated HbA1c in the first trimester so that you can prognosticate this particular pregnancy. If
Yes.
she is GDM, then we will do a HbA1c once between the second and the third trimester so that we confirm that this is GDM and it was not diabetes, which was not diagnosed earlier.
Yeah, yeah. But then what we are discussing, that whether for the anomalies you should, make the patient panic. That is what was that is in fact, the moment you diagnose her with screen positive, you have to differentiate between GDM and diabetes that we discussed. As you have rightly pointed out, the moment you diagnose it as hyperglycemia, you have to see whether she has this HbA1c high or it is normal. That gives you a control over last 3 months. Okay, so that is why we have to discuss all this with us. So you have to do all these investigations, dating scan, 11 to 13 weeks, CRL and knuckle translucency, and then of course go for the dual marker at the earliest, and anti-scan or even NIPT. Okay.
Ma'am, one very interesting thing I would like to add. Usually, when we are taught that these over diabetic patients, they have more chances of developing anomalies as compared to GDM patient, because for the GDM the glucose were normal at the time of the organogenesis, but there is one particular fetal abnormality which has got equal incidence between the GDM and diabetic mellitus patient,
Yes.
and that is the inspissated bowel syndrome.
Okay.
It is said that because of the hyperglycemia in the amniotic fluid, the bowel movements are disturbed. So short bowel, small bowel gets shortened, and less, there is hypokinesia, which will lead to inspissated. That has been recently added into the areas. Presently, there this GDM patients, if they are screened with HbA1c, that can help. But HbA1c still is not favored because of the physiological anemia. Hemoglobin as such dilutes. So we are searching for proteins which remain static between the pregnant and the non-pregnant.
Perfect.
Then we will study about the glycosylation of those proteins.
Right, right.
Nice information, Dr. Mohita.
Yes, Mohita, that's a very important information. And just to clarify one more thing I would like to add here, that whenever you do NT for such patients, it can be high, not only because of the aneuploidy, but also there is a possibility of congenital heart disease that you have to keep it in mind. Okay. So friends, let us move ahead. I think Dr. Mohita, once again, it's coming to you. So I asked Dr. Neha this question. So primary 16 weeks, parents are diabetic, and she comes to you with the following reports, GCT 179 milligram percent. Okay. So Neha, whether you will label her as diabetic, how would you like to investigate her?
Ma'am, I would definitely label her as GDM, gestational diabetes patient, and I would like to take control of control her sugar levels by the by diet control, exercise,
2 weeks time
and
you
then
give her.
screening tests.
Yes. You go for 2 weeks time. You go for MNT and active physical exercise and diet, and then after 2 weeks you do her 2 hours postprandial. That should be less than 120 milligram percent. Please do remember, all of you. Okay. After 2 weeks and throughout the pregnancy, whenever you do her glucose levels, the postprandial should never exceed 120 milligram percent. Please do remember, this is the most important message from this program. Okay, so now you have given her 2 weeks time, diet, exercise, and now 179, and 179 it is. So after 2 weeks also, suppose it doesn't come down or it's not controlled, then what will you do?
Ma'am, I can either go for oral hypoglycemics like metformin, or else I can switch her on to insulin. For that, I'll do her HbA1c, and depending on the levels of HbA1c and the repeat plus PPBS levels, I'll take the decision. I personally prefer metformins for such levels.
Yes, yes. So any difference of opinion here, Dolly? Dr. Dolly?
Same, madam.
Yeah. So basically, metformin, what this even FIGO guidelines say that, management should be in accordance with the available national resources. You can see this, what it is shown in what is the scenario in India. If you give insulin, if you advise insulin to a village lady who is totally uneducated, who cannot read and, cannot understand what calories and etc. You mean, if she's not able to monitor herself by self glucose testing, she can go into sudden hypoglycemia and she may not be even able to control her diabetes. And in this scenario, if you put her on metformin, that should be better. That is what the message from this slide, that it should be in accordance with the available national resources. It may not be according to the standard protocols, okay? But it is, it is something is better than nothing. To support this, actually, Government of India and NHM also say that now it has been proven beyond doubt that metformin and insulin are equally safe and effective. Okay, so no worries. Even though insulin is the first drug of choice, what we always say in the guidelines, metformin can be used safely, provided after first trimester. That is what it is, the clause has been mentioned. So, Dr. Rekha, what diet do we have, Dr. Rekha? Dr. Rekha? No?
She has not joined, ma'am.
Okay. Okay. So anybody can do. What diet modification? We have already discussed this
Discuss it.
modification. So we skip these slides. Huh? This has been already discussed. Any specific advice for exercise? I'm
Discussion.
Why Jagrati has not joined? This we have already discussed. The household work, stretching exercises, etc. Now during second trimester, what investigation you want to do, Dr. Sonal?
Fetal deco target scan at 18 to 20 weeks, or if the patient is over diabetic, we can also advise the early anomaly scan at 16 weeks. But the target at 18 to 20 weeks and the fetal echo at 24 weeks is very necessary for diabetic patients or for GDM patients to rule out any fetal anomaly and to counsel them accordingly, ma'am.
Okay. What about how frequently will you repeat the HbA1c and how frequently will you repeat the sugar levels, because she is not on insulin?
Ma'am, HbA1c should not be repeated before 3 months because it's a given idea of 3 months prior to glucose.
Agreed.
Yeah, and 2 weeks blood glucose. Yeah, and 2 weeks blood glucose monitor for patients who are controlled, or a self glucose monitoring for patients who are on uncontrolled blood sugar is usually advisable.
Okay, okay. So I'm purposefully trying to discuss today, taking short cases. So we just go to Dr. Dolly. We have this 20, we have this primary gravida with 20 weeks pregnancy. Parents are diabetic, and she comes to you with following reports: fasting sugar 95, postprandial 175. Do we report her or diagnose her as GDM?
Actually, the diagnosis of GDM will only be done after the OGTT test. But yes, I will consider her as a high risk for GDM, and of course, and I would directly advise her for the exercise and the diet control, as well as I would ask her to get the OGTT done.
Okay. So HbA1c, I think if you do HbA1c in this case, definitely you would have the idea whether for last 3 months she has had high sugar levels.
Yeah.
Yeah. So because 175 her sugar levels are already, and giving
Which is on the higher side, right.
Yeah. Okay. So this is what is the slide which I was talking about, that definitely metformin is also, equally effective. Metformin or insulin therapy is the accepted medical management for pregnant women with GDM, not controlled on MNT. And insulin is the first drug of choice, and metformin can be considered after 20 weeks of gestation for medical management. This is by Government of India, Maternal Health Division, Ministry of Health and Family Welfare. Okay, and even NHM. Okay, so what drug you want to start? Anybody has agree with glyburide, carbose?
No idea, ma'am. We
I
have
think
been using
metformin and
metformin only.
glibenclamide can be used. Rest, I don't think so. They can be used.
Yeah,
And glibenclamide also, if there is a contraindication to metformin, or if the patient is not able to tolerate metformin, only then.
yes.
Otherwise, metformin, insulin, and glibenclamide, nothing else can be used.
Right. So all these drugs, they say that, insulin is the preferred drug of choice. But yes, oral anti-diabetic or oral hypoglycemic agents, but preferably metformin, because this is the most studied, most evaluated drugs. So better to use, metformin. Now, Dr. Neha, in what situations you directly start with insulin and not go for metformin?
Ma'am, first is contraindication to metformin. If the patient is not able to tolerate metformin, then
No,
and when the blood
I'm
sugar,
saying directly to insulin, not
when the
you are not trying.
fasting blood sugar level is more than 120 and the ppbs level is more than 200, I will directly start on insulin.
Okay. Because yeah, so one is when we are doing the management of GDM, and after 2 weeks, if you find that MNT has not helped, postprandial blood sugar level is more than 120, that is one. And then secondly, as you said, fasting more than 120 and postprandial more than, means approximately 200. So having sugar of 200, that itself tells you that it is over diabetes, and best way is to go for insulin. Okay. So
Yes.
suppose you want to start her on insulin, how initially, because the sugar levels are high, you don't want the fluctuation. So how many times, how often do you want to monitor the sugar levels?
Once a day for fasting blood sugar level and then 2 hour postprandial levels after all three major meals.
Yes.
That
Okay.
means four tests in a day.
So ideally they say theoretically 7. Okay. 7 means 3 meals, pre-meal and post-meal, that is fasting and 2 postprandial, and one is either very
3
late
a.m.
night or 2 a.m., 3 a.m.
3
Okay.
a.m. 3 a.m.
So that is how it is.
Some of
7,
these phenomena.
which is totally impracticable, right? And that is why we have come up with this Indian solution of 4 times. Initially,
Ma'am,
when
a device that's like CGM is also a good option for these kind of patients in which we want to adjust the insulin levels as per their glucose levels. We can implant a CGM on these patients and get a sugar reading of at least 3 days, and then advise the insulin accordingly. It's very safe also and comfortable for the patients also.
yes, but of course the cost efficacy.
Cost is.
Yes,
Yes.
definitely cost is
So
there.
how much that single sensor how much you have to pay? At least 15,000 minimum, and every 15 days, maybe 15 to 20,000 every 15 days. I don't think our population, at least at present, is not. So definitely for those who can afford, yes, because you can directly get a monitor, you can get the reading with the sensor. Definitely you can use it.
Ma'am,
Yes.
one input, small input I would like to say. I advise my patient to have 1 rupee copy and get for last 10 days from 1 to 10 dates. I write them and
Yeah.
I tell them to take one pre and post breakfast on day 1, pre and post lunch on day 2, pre and post dinner on day 3. So
Yeah.
sometimes actually our patients, they don't take meals regularly and of regular quality. Say for example, some festival is approaching, so that day they will have some other type of food. So if we have a 10-day score,
Yeah,
that gives a more comprehensive look, and it is more cost effective also.
definitely
same thing.
maintaining a good diary is definitely, because that is what I'm doing. For my patient
Yes,
always
but
comes with a notebook. Yes. So she,
yes,
she
but
will tell me how much.
that requires a comprehensive input from the patient side also. That I
Yes.
agree. But
Yes.
where we can be feasible, it can.
See,
The same as
even the uneducated or minimally educated patient whose husband is also good in, because we involve them into the management and we teach them even to give insulin. So the husband keeps the record, and she herself keeps the record and comes up with a diary, and that is fantastic, because you can attest with
fantastic.
You can see that her glucose control was definitely good, and she herself can, notice that, there is a problem. So sometimes they call you, madam, this has happened, now what to do? That's the
Yes, ma'am.
best thing you can have. Okay. Now, how do you monitor this pregnancy ahead in third trimester?
Ma'am, sorry to interrupt. I want to give
Please.
my input.
Yeah, sure.
Actually, when we take the sugar level from the glucometer, then also we should ask the patient to get it at least within 15 days or every third day. If initially when we starting the insulin, then every third day blood sugar fasting and ppps at least from the lab, because glucometer readings, they can
There is
vary. They
definitely
are
a very
variable. And there could be a patient, even if patient is having sugar level more and the glucometer will show less sugar, so that will be problem in the management.
Definitely, very well taken, madam. See, basically what we said, that once she settles, yes, then you can go ahead with these type of monitoring, the home glucose monitoring.
Yes,
But
ma'am.
till when you put her on insulin, definitely four times a day you have to take all those reading, and every third day you have to repeat and see that she's really well stabilized on this dose of insulin. Then of course she can maintain her home diary. So point very well taken from your side. Thank you. So Dr. Nidhi, we don't have, I think we have only 3 panelists. I think anybody can take up. We are taking the cases, as open discussion. We have this, I think we'll take up this as a last case. Primary gravida, 33-year-old patient, 7 years infertility. She was obese, PCOS, conceived on metformin, and she was diagnosed at GGM at the first visit itself. So now she's controlled on MNT, but her HbA1c is 6.9 at 33 weeks, and she's got macrosomia. Where things have gone wrong, and how do we manage now?
This shows that the control was not good. Somewhere, the readings were not good. The patient was not compliant. And hence, she has developed macrosomia, or say polyhydramnios is also there if, the patient doesn't control her blood sugar levels.
Yeah,
And
but
so
then,
here, is the
what has
role.
gone wrong? What has gone? Why it has happened? We are saying that, she's controlled. But what has, she was, see, I give you a hint that she was on metformin, and still she was diagnosed
She
as
should have
She
started
should
with
have been on
insulin.
insulin.
So that is how,
Yeah.
and if she, with metformin, if she can have glucose intolerance, then that means that even she is not controlled on metformin. Okay. So that itself gives you a hint that, insulin should have been the drug of choice the moment she is diagnosed. That gives you a very concern. So she is a patient where you have no option but to go for insulin, right?
One more thing, ma'am.
Yes.
As you told and you are telling again and again, because on metformin, if doctor is taking that the 140 blood sugar is normal with the metformin, then also the baby can develop macrosomia. So as you were telling that the blood sugar should be less than 120 when patient
Yes,
is in MNT.
postprandial, definitely. The postprandial sugar levels has to be less than 120. At no point of time it should be more than 120. That is what the statement is.
Yes,
and HbA1c 6.9 definitely is not a good control during pregnancy, right? Okay.
Yes.
Yeah. So GTM diagnosed before 20 weeks, obese PCOS, insulin should have been the first drug of choice. She should have been, advised for strict diet restriction and regular physical exercise. HbA1c 6.9, I would say not a good control, but okay, the fair control. And she has to now control whatever you have in your hand. Now 33 weeks onwards. Dr. Mohita, how will you manage her?
Yes, ma'am. Sorry, ma'am.
Yes, 33 weeks. No, she's got HbA1c 6.9. She's got macrosomia. So how will you manage her now?
Ma'am, such patient should first be evaluated from maternal and fetal, both parameters. From fetal parameters, the best one will be the biophysical profile. And from maternal, I would also like to screen her. This will be the best time to screen her for some of the organs which are being involved, like her renal proteinuria, development of PIH, because in 10% of the cases, there may be an additional BP that thing. Then the most important thing is still is the rise in the fundal height. If the growth rate is very high, abdominal circumference is rising at a very high rate, or the patient is having a rapid weight control, rapid weight gain. So those patients should be frequently adjusted. Their insulin should be frequently adjusted. This is a at this time one counseling session with the parents, because this is the time where even one episode of hypoglycemia during the process of decrementally controlling the sugar may lead to hypoglycemia and loss of the fetus. So these are the patients between the 33 to 37 week more likely to have sudden catastrophes. To prevent them, daily fetal monitoring count, a detailed counseling session to the patient for warning signs, daily fetal movement count should be given to her. Then diet, again all those points which we have covered till 33 weeks should be revisited. फिर उसको मैम इंसुलिन का जो वो है रिवाइज करेंगे थेरेपी को, और उसके बाद में पेशेंट को बायोफिजिकल प्रोफाइल से देखेंगे और
15 hospitalize her. Hospitalize. Yes. Now you can say anything, because hospitalized, because she was being managed by on outpatient basis, right? So first thing is to hospitalize her, and then you have a tight glycemic control, as you are saying, the insulin and the every what you are saying, the 4-point testing. Again, you have to go for her. So maternal monitoring, fetal monitoring, what you are saying. So such women should not, otherwise if you have a high risk pregnancy, you try to deliver them maybe after 34 weeks, because you have the risk much more beyond 34 weeks. But for diabetes, all of you know that even at 39 weeks, sometimes the baby lands up into respiratory distress if the mother has diabetes. So here for this patient, absolutely no preterm induction or delivery, correct?
Yes, ma'am.
Agree?
And I would like to add here, ma'am, that even the Dopplers will not predict an SB, because here the pathophysiology of SB is different. So the Dopplers will also not predict that there can be an SB in future. So the patient has to be counseled very well, as Dr. Mohita said, that you have to sit with the patient and the attendants and tell them the importance of daily fetal monitoring count.
Perfect.
Daily kick count.
Okay. So even the macrosomia, now that she has been diagnosed with, but otherwise macrosomia is not very easily picked up by ultrasound. The accuracy, sensitivity is very poor. It's only 51% even in third trimester. So it doesn't give you early indication of macrosomia, right? So serial abdominal circumference indicating 75th percentile, that tells you that yes, she's going into macrosomia by the time it is too late. Right? So you have to salvage this baby from here. So you have to take a tight glycemic control, and still you prepare the baby for, preterm delivery. If at all that baby, you may have to take the decision. So go for steroids. Now, what steroids, how much? And your patient is now already hospitalized.
Yes, ma'am.
Any problem with the steroids?
Ma'am, steroids are theoretically they are said to cause hyperglycemia, but in an admitted patient, the steroid therapy can be safely given to a diabetic mother also. The only precaution is that whole dose should be given early in the morning, because whatever the derangements are, they can be safely adjusted. So with admission, I would like to give the same very doses of steroid, but I would like to shift the timing to the early morning hours.
So basically, whenever you give steroids, there is definitely some disturbance in the glucose control, right? And you may have to readjust your insulin dosage. And that is why if the patient was not admitted, maybe for this, we have to hospitalize. But if the disturbance is not much, definitely you can manage on even the domiciliary pressure. This is the hypothetical condition. Here, our patient is already hospitalized, so you have everything at your stretch and you can monitor the blood sugar levels very comfortably, right? So what I was trying to say, that once you give magnesium sulfate for neuroprotection, give steroids also, because you don't know when she is going to land up into preterm labor, because macrosomia and fluctuating sugar levels, you have to be very, very cautious. So that is how you have to prepare this baby. Maybe you don't be in a hurry to deliver, but you prepare this baby. Okay. So when do you deliver? Now, ideally, in this case, yeah. But when should you deliver the patient, and how should you take the decision whether she should deliver vaginally, by cesarean section? How?
Ma'am, delivery is advised usually within 38 to 39 weeks. At 38, 39 weeks, if everything is going well, at 38 and 39 weeks, I'll assess the patient. If her, like for expected fetal weight, if it is appropriate for gestational age, the sugar is proper control, the patient is compliant, and everything is going well, then I would like to continue her and wait for her to go into spontaneous labor. If the baby is
you want to induce or go wait for spontaneous even at 39 weeks?
At 13, I can wait till 40 weeks, ma'am, because the diabetic babies get a pulmonary maturity at a later gestation. Na? So I would like to wait for till 40 weeks.
Controlled GDM controlled on diet goes to 40.
Yes, okay. Controlled. Yes, the control one.
And diet. Yes, that is okay.
It's 40.
But
insulin dependent patients,
they
they
are
after
talking
37.
about a patient who is on insulin already, right?
37 weeks, madam. 37 weeks she should be induced.
Okay.
With keeping into obstetrical factors in view.
37 completed 38 weeks. Okay.
37 completed 38 weeks. And the induction will be planned early in the morning. Her insulin dose in the night will be given.
My dear, what about macrosomia?
मैम मैक्रोसोमिया में मैम 4.2 kg का उन्होंने लिखा है, पर वो सीपीडी को दैट इज अ थ्योरेटिकल रिस्क.
Yeah, but you say it out.
That हमारे डाटा में है, पर हमारे तो 3.8 भी अटक सकते. शोल्डर डिस्ट्रोशिया हो सकता है.
Yes. If it is more than 3.5 kg, there is no point in inducing the patient. We can directly go for cesarean.
That is why I'm pulling you again and again here, because definitely if she has macrosomia, so even according to FIGO and all those guidelines, if the estimated fetal weight is more than 4 kg, she's directly for cesarean section, elective cesarean. That is what. So for us, I think it is more than 3.5. Okay.
3.5. Yeah.
Correct? Yeah. So what I would say that if it is more than 3.5 or if it is macrosomia, we go straight away for elective caesar. Now suppose if it is less than 3.5, things are stable now, mother and baby stable, 37 completed weeks, you induce her 38 weeks. Okay. And then you look for whether she can deliver vaginally. If it is definitely, if there is fluctuations in blood sugar levels, you don't wait for even inducing, right?
Theoretically, induction and all sounds good, but in private practice, I think we'll go for directly elective cesarean.
That is what we are saying. No, that is what we are saying, that if anything you find unstable, even your mind, because you have no explanation, even if you counsel the patient and relatives, and if you tell them no, that till now everything is okay, but beyond this we are not sure, because nothing is in our hand. If it is FGR, we can have Doppler parameters, we can have even for HDP we can control the blood pressure. For GDM we can control the blood sugar, but we have no control on the baby's prognosis. And that is why even the books say that even beyond 39 weeks, for a non-diabetic patient also, there is what is called as inevitable stillborn, okay, or inevitable unexpected fetal death. Likewise, for hyperglycemia, you definitely have higher incidence of unexplained stillbirth beyond 38 weeks. So best way is to go for elective cesarean section. I think if you discuss with the patient and relatives, it's called as an informed decision making. So I think that's a way of practice, even theoretically and practically acceptable. So definitely all of us agree to this consensus. That is good enough. I think this is what is the FIGO consensus of FIGO algorithm I have just posted for your. So if everything is fine beyond 38 weeks, yes, you may try to induce more than 4 kg straight away for seizure. Yeah, and if it is, anytime it is less than anytime you have some problem with maternal or fetal condition, you go for cesarean section again, once again. So we will not discuss now any other, only one question, I think one aspect we will discuss, that is, suppose you have a elective seizure and your patient is on insulin, what will you do for that particular day? For insulin, whether you will give her morning dose of insulin or no?
Insulin is only given at the night at the regular prescribed doses, omitted into the morning, and sliding scale is used, ma'am, for the management. So up to 180, 2 unit of insulin, from 180 to 240 additional. For every plus 40 sugar, we add 2 units of insulin.
Yeah.
So we will give her the fluids. We will monitor 4-hourly sugar, and we will go for management of insulin according to the sliding scale. Better is to go for human insulin, which has got a shorter
You're
duration of
right,
action.
but what I'm not getting my answer. What I'm asking is, if at all your patient is, she suppose, how do you titrate the insulin? Suppose with your insulin dosage at night, single dosage, if at all, or maybe at breakfast, you adjust the insulin dosage. So if you have, the fasting sugar more than, it is more than 95, then you have to add 2 units at night also. Okay. If your postprandial is more than 120, then you increase 2 units at the breakfast. Okay. So that is how you have to increase. But then suppose your patient is on regular insulin and you are posting her for elective seizure, should she take that particular day's insulin? That is what is my question.
Only nights, previous nights insulin. Morning dose is omitted.
Yeah, so you have to skip that particular dose. That is what is the only answer I was expecting. Otherwise, your explanation is right. So how do you monitor the sugar levels? How frequently, and what should be the level during labor, if at all your patient goes in labor? So the sugar levels have to be monitored every hourly, and at no point of time it should go beyond 100, 105. Okay. So, she should not be hypoglycemic. Otherwise, she has a very high chance for going into diabetic ketoacidosis. This patient needs to be hydrated very cautiously, because dehydration is the single most common cause of, diabetic ketoacidosis. Okay. So can we have some comments from the expert?
Yes, ma'am. You have explained very well, and all the panelists were wonderful. They were very interactive, and they have given very important inputs as well. One more thing I would like to add, that the sudden IUD, whatever we are doing, we are every time when we are examining even these patients, we have to explain them sudden IUD, because even if everything is going well, then also sometimes it happens that patient may get sudden IUD. So we have to just explain them also, and it should be in writing in our prescription paper, that this risk has been explained to the patient. And when we do the corticosteroid treatment to the patient, sometimes with a little bit increase in the sugar level, it also causes patient may complain with a little bit increase in sugar level that she is having reduced fetal movements. Some of the patient, they come up with this. So we have to tackle, and such patient should be admitted if they are complaining that they are having reduced fetal movement. So that is my input.
So
thank you so much, ma'am, and it was wonderful panel discussion. Although some of the panelists were not joined because they stuck up.
Dr. Mohita. Yes.
Ma'am, I think we are concluding. So I have just one beautiful poem that was written by Samuel Taylor. The poem was titled The Reign of the Ancient Mariner. And there he has actually compared the situation of a person who is drowned in an ocean. So there he has written the albatross across his neck. So what happens is, there is water everywhere, not a drop to drink. You are so you sunk in a water body, but still you don't have a water to compile with the thirst. Same is with diabetes. There is sugar all around the cells, and still the cell is under the anaerobic metabolism.
Yes.
So the mother's metabolism should always be considered. What will be happening is a small this muscle ischemia. She might complain of increased restless leg syndrome, small things, fatigue. As ma'am has rightly put, she might not be able to appreciate. So the anaerobic glycolysis and the accumulation of these products of anaerobic glycolysis should always be considered at the mother side also. And this I just wanted to add. And one thing, as you have said, that the abdominal circumference, serial measurement of abdominal circumference, it can only, this cannot suffice with the development of macrosomia. So increase in placenta, there should be studies on increase in placental thickness with borderline AFIs, with say more rise in AC. It should not be the fetal weight at that particular moment of USG, but it should be the rise in the abdominal circumference along with the placental thickness and the liquor pockets. Because all diabetologists from all other specialties, they are not managing the patient according to the sugar level. They are managing according to the end organ damage caused by diabetes. We obstetricians are still practicing on RBS, and what should be the sugar values. Our end organ should be the fetus, the placenta, and the AFI, and we should, from the third trimester, should focus on our end organ and titrate according to that management more than the sugar levels.
Yeah, in fact, if you have seen initially, actually we skipped one more case, I think. We always talk of the complications of diabetes or hyperglycemia, and we say that, vasculopathy, nephropathy, and retinopathy. These are the three main complications for them.
And ma'am, neuropathy, before the major neurons are affected, it is the autonomic neuropathy which manifests first. So these diabetic patients, they will complain of alternate diarrhea and constipation and increased levels of sweatiness.
So this was the case, actually, we wanted to give that message, but we have to skip because of the time concern. She was having hypertension also simultaneously, okay? So we discussed the, end organ damage only. When I have taken that 3 trimester, how you should monitor the mother and the fetus. So all these investigations should be done to confirm that she's not landing up into end organ damage or, the complications of diabetes mellitus. That should be our prior. Mother's life should be first, of course, and then we have to do timely and appropriate intervention so that we save both the mother as well as the baby. I think that should be all from my side. And
one more thing.
Yeah, please.
If the patient is diabetic or GDM, and along with that, if she is previous section, such a patient, they have got more chances of scar adhesions. Just because of autonomic neuropathy, there are more chances of silent scar adhesion. So we should keep that in mind as well.
Yes, definitely. So from this platform, first and foremost, I take this opportunity to say that don't take hyperglycemia and pregnancy as a very lightly. Screen each and every woman during pregnancy, and during every pregnancy. I would say first pregnancy it was not there, that doesn't mean that she'll be spared even during second pregnancy. So you have to screen each and every pregnancy, and definitely at first visit 24 to 28 weeks. If at all the lady is obese, and even if she has GGI, gestational glucose intolerance, you have to screen once again at 32 to 36 weeks. Okay, so not to forget that. On insulin, we have already discussed it at a stage, but I have already discussed about the, making the diary of the insulin and the sugar records, because that's the most important thing. You get the average blood sugar levels, and you get the trained whether she can land up into hypoglycemia. So that is very, very important. So friends, that is all from our side. I think even if we, all of us keep this in mind to test each and every patient during pregnancy as per the recommendations and manage it very effectively. Of course, give antenatal steroids and Maxelf if at all we have to, intervene earlier. Definitely, we have to be, we have to be prepared for all the complications. Of course, all of us have discussed it well. So with this, I thank all the four, of course, Dr. Kavita Singh, the president of AMPOGS, the guest of honor, Dr. Madam Leela Joshi and Madam Nina Gideon, and of course, all the four presidents and secretary of four societies, Riva, Ratlam, Sagar, and Katni, all my dear friends, the esteemed panelists. I would like to, convey my heartfelt thanks to Dr. Binu, a dear friend, the revered speaker who has delivered very well, and Dr. Anupama Dave also I would like to thank. All my esteemed panelists, very well read. Thank you so much for your, contribution. Your discussion has added value to our discussion. Your inputs have added value to our discussion. And friends, I would like to just take this opportunity to humbly seek all of your blessings and support. And my request to you personally that I'm one amongst you. So please, and you have been, watching me from so many years. I have been working for Foxy since last 25 years, even though I'm a private practitioner, and I'm following my passion for academics as well as social work. So please do make me as your first choice and vote for me. Thank you so much. Thank you.
All the best, ma'am, for your future
Best wishes, ma'am.
elections.
We all are with you.
Definitely, you will be more than 4,000 par hoga aapka is bar.
Thank you.
Definitely. All
Yes.
the best, madam. All the best.
All the best.
All
Thank
the
you
best,
so much.
ma'am.
Yes,
And thank you very much.
Thank you, madam. Thank
Thank
you
you,
so much.
ma'am. Thank you,
Thank you so
everyone.
much. Thank you.
so much. Thank you.
Thank you. Thank you. Thank you. Hi, Neha.
Hi, ma'am. Ma'am, there is a question in the QA box.
Yeah.
Why metformin is not given in first trimester?
So actually, the answer to this is, sometimes people ask. I'll give you the answer first. That because it has been not extensively studied, they say that it can be teratogenic if it is used during first trimester. There have been discussions that patients of PCOS who is conceived on metformin, and if she becomes, if she is conceived, then should we stop her metformin? So the answer to this is, if at all you do her OGCT and you find that she's negative for GDM, there is no role for continuation of metformin. That is one. But if at all she is positive for GDM or screen positive for GDM, because in spite of being on metformin, as our case we discussed, that she developed GDM. So there's no protection by the metformin. That is why you should not continue metformin during first trimester. Simple. Did you get it? That if
Thank
at
you,
all,
ma'am.
yes, even when the metformin is given, it is continued, she is having GDM. That means she is not protected from that. So in this situation, you have to start with insulin. Whereas on the other side, if at all you do her OGCT and she's negative for GDM. So if negative for GDM, why you want to continue metformin? These are the three different answers to this question. But as long as the evidence don't support us, that you can use metformin very effectively, safely, we should not use. Because tomorrow if somebody charges you, then you have no support from the evidence, right? So thank you so much once.